How is everyone?
Okay. He is from Lebanon, actually, so he's joining our webinar on medical disorders during pregnancy. How are things going in Beirut, Fadi?
Amir, it's challenging. It's challenging.
I know, my dear, I know.
Our sector is struggling big time. We've lost half of the department, and I'm almost out the door, Kamena. So I'm not going to stay much longer. Yeah.
You're going to the States? You're back to the States?
It's States, or I might do Dubai. I've been coming to Dubai for the past year. I've had a practice here, so it might be easier for the family. مع انه I've accepted a position in the US, بس هلا we're kind of having second thoughts. But I really need to get the kids out of the country. It's getting too toxic to raise a family, especially when you have teenagers.
I know.
Unfortunately.
I'm so sorry. I'm hearing the news from all my friends, and I'm really sorry what's happening there.
And it was our fate. It was inevitable. It was inevitable. It was going to happen. It just happened too soon, too fast. The collapse happened too fast. But it will rise again one day.
Definitely.
But unfortunately, at that point, it's better. We're better off outside the country, at least for the sake of the kids.
So, Fadi, what percentage of your doctors have left Lebanon now?
A lot. Half of my department. Mahedin Saud has moved to Abu Dhabi. Johnny Awad has moved to Qatar. Antoine Abu Musa has moved to Iraq. Labib Ghelmi has moved to US. Joseph Nassif has moved to US. Jihad has moved to France. This is half of my
department. No one left. And who is going to look after the university hospital?
Half of the department's still there, and we're recruiting now juniors. Unfortunately, we have departments راحت كلها. Neurology, we're left with one out of 5.
Yeah,
it's bad. It's bad. With all the retention plans and the millions of dollars that the university has put in, but it's more of that. It's more than that. It's really the quality of life. That's the problem. The safety, the security, the healthcare in general for your family, the education for your family, So this is really our concern for those of us who are leaving. This is the main issue, more than the economy, etc.
Yeah, so sad, Fadi. I'm so sorry to hear this. And I've sent you 2 patients, and they told me that Fadi is leaving.
I've started telling people, especially the pregnant, back in April, I'm going to be leaving any minute. I was just waiting for the kids to finish school, kind of figure it out, and then we'll leave probably by the end of summer, inshallah.
It's hot over there in Dubai now. It's almost 50 degrees.
Yeah, exactly.
Yeah, so you definitely have to enter.
We can't start, my friend. Brahim?
Doctor.
Yes?
يلا
نبدأ. It's 7 o'clock. I think it's 7. Yeah, please. It's
yes.
7 p.m. time. Yes.
Excellent. Well, good afternoon, my friends, and I welcome you to our 6th webinar, which is organized by the Jordanian Society of Obstetrics and Gynecology in collaboration with the representative committee of the RCOG. We have an excellent session today with excellent speakers, and I hope you will enjoy all the talks. Now, the talks are for 20 minutes, and then we have a Q&A session. So if you have any questions, then put them in the Q&A. And we will start with Dawn Adamson. She's going to talk about acute cardiac emergencies in pregnancy. She's a consultant interventional cardiologist with special interest in heart disease in pregnancy. Associated Medical Director, University Hospital of Coventry and Warwickshire. She got a PhD in cardiac physiology at the National Heart and Lung Institute, Imperial College. She has lectured both nationally and internationally on the subject of cardiac disease in pregnancy, and she has written the Oxford Handbook of the Heart Disease in Pregnancy. We are delighted that she can have the time to be with us, and she's on call, by the way, but she
Ibrahim.
دكتور مازن دكتور مازن كمل.
Okay, John, the floor is yours, my friend.
Yeah,
Thank
okay,
you.
go ahead.
So can everyone see my screen?
Yes, we can.
Lovely.
Yes, we do.
Thank you very much for the fantastic introduction and for this. Really pleased to be able to talk to you today. I'm going to gallop through, so I will apologise for the amount that I'm covering, but in 20 minutes I'll be flying through, but hopefully you'll be able to, we're recording this session, and if you've got any questions, then I'll put my details at the end. Always feel free to email me or question me, I really don't mind. So we're going to be talking about acute coronary syndromes, pulmonary edema, aortic dissection and arrhythmias as the four main emergencies that you'll be seeing in pregnancy. So as I understand in Jordan, heart disease is the UK's biggest cause of maternal death. And this has been an ongoing problem, and you can see the data here from our for our Embrace report, which clearly shows that cardiac disease is far greater than any other of the conditions that you'd be worried about in pregnancy. And what's important is that despite the advances in care, the things that we're doing with primary angioplasty, with devices, etc., we're seeing this mortality not reducing, and it's really important that we therefore try and understand it. We think that the experience is getting less. What we do know in the UK, I don't know if it's the same in Jordan, is that 3/4 of these patients are not known. So we do a lot of work with pre-pregnancy counselling, but one of the problems is to have a low threshold when someone presents to you that this actually might be the first time that a diagnosis needs to be made. So it's always something that we try and push very much within our trainees in our obstetric community. We know that mortality is only the tip of the iceberg. So whenever you're seeing cardiac disease, it does lead to a lot of morbidity with arrhythmias, heart failure, hospital admissions, a lot of patients, a lot of multidisciplinary work goes into looking after these patients. And it's not just obviously the mothers, we concentrate on those, but there is the associated problems of prematurity, fetal loss and terminations that we sometimes have to advocate. So what is causing these women to die? Some of it you'll be expecting. So we do see cardiomyopathy, whether it's predisposed DCM or peripartum cardiomyopathy. But interestingly, 1/4 of the deaths of some form of acute coronary syndrome. And people worry about, acute coronary syndromes with regards to the classic, plaque rupture, but remember that you can get coronary disease on normal coronaries. We see a little bit of valvular heart disease, and we do see this sudden adult death syndrome. So these are people that are found dead from assumed arrhythmic death, but their hearts are morphologically normal. So we're still trying to understand these a little bit more. Dissections in there, and then obviously there's things like pulmonary hypertension, myocarditis, etc. What you will only see is only 4 congenital heart disease. So whenever I say to the patient, this is a patient with tetralogy of Fallot or arterial switch TGA who's pregnant, that makes most cardiologists go a funny shade of grey because they get very worried about it. But actually these women are so well assessed and have such good pre-pregnancy counselling that in the UK, that despite them having put some of the most complex heart problems, we're not seeing the mortality associated with that. So it does show that if you can put a lot of work into them beforehand, then obviously that's one good area that you can reduce the mortality. Okay, so let's start with acute coronary syndromes. So STEMI is our obviously thing that we worry about the most. And what I would say is do everything you would do to a normal patient having a STEMI almost. So what I mean by that is in the UK, we use aspirin and ticagrelor as our dual antiplatelet therapy, but we've got no data for ticagrelor. So if I know the patient is pregnant, then I would use clopidogrel. If you don't know, or that they get given ticagrelor in the community, they can be converted to clopidogrel afterwards. 1 or 2 doses is not going to be a problem. We know that heparin, whether it be unfractionated or low molecular weight, is safe, so it's absolutely fine to take these women to the cath lab, but do not be afraid. When we look at our UCOS data of NSTEMIs, actually, a lot of these women were not taken to the cath lab when they had an acute coronary syndrome. We look for any other reasons why the troponin is up. We look for ways to medically manage them that you just wouldn't do when they weren't pregnant. And what we want to try and get across more than anything is do not be worried about the radiation. There are things that we can do in the cath lab to minimize the radiation, but the most important thing is to get the right treatment for the woman. Obviously, if you don't have access to primary PCI, then thrombolysis can be used in pregnancy, as I'm sure you're aware. So with an NSTEMI, the history is the same as in a non-pregnant woman. And what I mean by that is most women do not have central classic chest pain raiding up into the jaw and down to the arms. We're very difficult to read, and we often present in an atypical way. And the other thing is, I've seen my last ACS was a 28-year-old triathlete, slim, fit and well, totally active. She had classic pain, T-wave inversion on ECG, a raised troponin, but the local team did not think it was an acute coronary syndrome because she just didn't look like the sort of person that would have an acute coronary syndrome. But actually she had SCAD, which is spontaneous coronary artery dissection. So we know that young fit women can still have acute coronary syndromes, either from the etiology of SCAD, the tearing of the artery, or they can have thrombosis on normal coronary arteries. As we know, pregnancy is a prothrombotic stage. So I think it's having that low index of suspicion. As I said before, troponin is normal in pregnancy, so if it's raised, you need to be concerned. There are some papers that talk about a raised troponin in preeclampsia. However, they don't reach the threshold for diagnosis of an acute coronary syndrome. So if you see a raised troponin, think about what is the cause. Now, we know that there are many causes of raised troponin. It's not all coronaries. Pulmonary edema, pulmonary congestion, arrhythmias can do it, but you need to have an etiology for why that troponin went up. D-dimer, I spend my whole time saying, please don't measure it. It's abnormally high in pregnancy. People try and measure it in the hope it'll be negative and reassure them. It isn't, and it won't. So what about the drugs that you can use? Well, I've already talked about the dual antiplatelet therapies and heparin. Beta blockers, there's a big push to say that beta blockers can't be used, but we're trying to push to say they can be used. I use them all the time. And in fact, I'm not seeing the IUGR, the intrauterine growth restriction that we were concerned about. We do know that you do get that if you use atenolol when used in the first trimester, but we tend to use bisoprolol and metoprolol predominantly in the UK. And certainly I've got a database of 8 years of data now of using beta blockers for whether it be for coronary disease, arrhythmias, dissection, etc. And we're just not seeing the IUGR that people were concerned about. We know that ACE inhibitors are not safe in pregnancy because of the renal effects. And nitrates, there is no concern, but be aware that often they can cause a more precipitous drop in blood pressure if the woman's a little bit underfilled, which obviously can often happen in pregnancy. Statins, are they safe in pregnancy? We're starting to see some data that you might be able to use them, but at the moment the advice is not to. And cholesterol does increase 40 to 60% in pregnancy. So be careful of measuring it in pregnancy because all it'll do is frighten you and then you've got nothing you can do to bring it down. So if you've got pulmonary edema, you need to think of the causes. So think about cardiomyopathy, and if you see it, as an always assumption, it's a peripartum cardiomyopathy, but it actually might be a cardiomyopathy that's been there for a while. It might be a DCM that's been unmasked because of the pregnancy, but the etiology can all be sorted out later. The management of the pregnancy, the delivery, and immediately post-delivery is the same. Obviously, we need to look at valvular heart disease. Mitral stenosis is often the classic one that's picked up in pregnancy, but increasingly in the UK, we're seeing a lot of aortic stenosis picked up because bicuspid aortic valve is one of the commonest congenital lesions. 1 in 100 patients have it, and a lot of people don't know they've got a bicuspid aortic valve. We're not doing as much screening as maybe we should do ideally, but that's something to think about. Obviously, they might have unknown structural heart disease, and we see a lot of patients from Eastern Europe, and I've picked up a couple of congenitals by picking up structural heart disease in that way. And then just the last group that you may or may not see a lot of, we have a lot of Afro-Caribbean and Black patients in our country sometimes, and essentially what these patients often have is diastolic dysfunction. So they have quite stiff hearts, and that's fine unless they have a big fluid shift. So either they have a postpartum hemorrhage and we fluid resuscitate them, or the autotransfusion, for example, after a twin pregnancy, and that sudden rush of fluid into the circulatory system they don't cope with, and they can go into pulmonary edema because of the high end diastolic pressures. You see the same sort of phenomena in patients with HOCM. So patients with hypertrophic cardiomyopathy, particularly if they don't have obstruction, is not a concern in pregnancy, but they don't cope with that big fluid shift at the actual time of delivery. So you just need to be aware of that. Lots of simple things to do. So whenever you see them, often they come into our A&E department, so they're on a nice flat trolley. So the first thing to do is get them on the left lateral and get the bump off the IVC to increase the venous return. Diuretics can be used safely. Often in heart failure, where we can't use, sort of out of pregnancy, in heart failure, when we can't use an ACE inhibitor, we use something called the Bidil treatment, which is a combination of nitrates and hydralazine. And we use that as an alternative to ACE inhibitors in patients who've got significant renal impairment. So these are great drugs that can be used in pregnancy as an alternative. So that's what I will be looking at in the pregnant woman. And obviously, if you've got concern about mitral stenosis, then that's the time when you would use beta blockers in the more acute phase of heart failure. Otherwise, we use it in the recovery. And that's because in mitral stenosis, as the patient gets more tachycardic, that reduces the time in diastole, so reduces the time that blood's flowing through the valve, and therefore reduces left ventricular filling, and you end up in this spiral of basically deterioration and catecholamine drive. So that's the time when, if you give beta blockers, you can actually interrupt that and basically get the patient out of pulmonary edema. Always beware to escalate. Again, I apologize, I'm not familiar with the healthcare system fully in Jordan, but one of the problems that we say is these women, often by the time they present, they've compensated. They're often young and reasonably fit, and they compensate. And then when they do crash, there's often not a lot of time and a lot of place to go. So if you have got a patient that's requiring CPAP, BPAP, or inotropic support, make sure that you think about whether, if they deteriorate further, you've got that escalation. So for me, I run a full regional obstetric service, but I don't have LVADs here. So if I do end up in this situation, I do make sure that I get them to my local LVAD transplant center. They can always send them back if they settle down, but it's certainly something to think about because these women can deteriorate quite quickly. Okay, galloping through aortic dissection, something that most people really don't want to see, and sadly is a cause of at least 2 or 3 of the 6, 7 mortalities that I've had over my whole career in pregnancy. So most people are familiar with the classic risk factors, so Marfan's, Erlos, Danlos, but be aware that, as I said, a significant number of aortic dissection occurs in patients with Turner syndrome, and also bicuspid aortic valves, which therefore will not really have any phenotypic abnormalities. So may just, may look as normal as you or I. So obviously we just need to be aware of that. So the classic symptoms are the sudden onset tearing, the chest pain radiating to the back, shortness of breath. If the patients do start to have hemoptysis, collapse, or faintness, then obviously we're getting to quite severe dissection. But the symptoms, it's depending where within the aorta it dissects. Obviously, if it dissects all the way back to the root, you might get the symptoms of acute AR, so pulmonary edema, and obviously if it involves the coronaries, then you're going to get ischemia. And that's where we look for the new onset AR murmur. Obviously, there'll be tachycardic and tachypneic, even just with the pain. And obviously, if you've got signs of acute MI or stroke, then you really have got a type A severe dissection and you're in a sticky time. So people often ask what the treatment. Well, obviously, first we've got to investigate. So a chest x-ray is ideal. If you've got on-site quick echo, then you can do it. But just be aware, sometimes in a pregnant woman, getting images good enough for you to say, this is a dissection, I am going to deliver the baby now and put her on bypass and open her chest. You've got to be a really good echocardiographer or have fantastic views. So to be honest, I think the main thing is get that patient into the CT scanner. Here in the UK, we have CT scanners in every one of our emergency departments. Get her into the CT scanner, and there you can see you're looking for a nice dissection flap. So what's the management when you find one? Aggressive blood pressure control. So labetalol and hydralazine are the normal first-line drugs. But again, these are very familiar drugs in obstetric units, but often these women present to ED. ED tend to not use labetalol and hydralazine very often. So if that's going to delay you getting those infusions on board, you can use GTN, because that is something that's used very familiarly. And then once you've got them in another place, you can then swap over infusions. Just get going with what you've got at the time that you can use. And also aggressive pain relief. There was one dissection where the team were concerned about giving her too much morphine because they knew that they were going to have to deliver the baby quickly and they didn't want a flat baby. Most pediatricians can cope with a flat baby with a bit of naloxone and respiratory support if necessary. Get the pain relief in because it reduces the tachycardia and the catecholamine surge, and then means the dissection doesn't dissect further. And then you just need to basically deliver the baby. Obviously, if the woman is before 24 to 28 weeks, you might make the decision to keep, if the patient's in the first or early second trimester, then you just get on and do the surgery. But if the baby's viable, then you just need to make that instant decision. Are you going to deliver or leave the baby to take its chances? And that's obviously a very quick and complex decision, though. Okay, so we're galloping through for our last 4 minutes. Arrhythmias. So the good news is bradycardias are extremely uncommon. They're often kind of vagal due to caval compression from the fetus. It is a recognized effect of spinal blocks, but most anaesthetists putting them in are well aware of it and have a range of syringes in their pockets to counteract it. It's very rare that pacemakers are required. However, tachycardias are much more common. Certainly SVTs are not infrequent. And the good news is vagatonic maneuvers are absolutely safe. So we always recommend those first. Adenosine, which is also is a drug that's used to treat and terminate SVTs, is also very safe. But just be aware that due to the increased intravascular volume in pregnancy, the enzyme adenosine deaminase, which actually breaks down the adenosine, basically means that it's more effective. So often these women need less adenosine than you would give outside of pregnancy. So as a hairy-chested cardiologist, I tend to go straight in with the 12 milligrams, but actually if I see a pregnant woman, I will go in with 6, 12, and then 18. If you've terminated it and the patient comes back and you need a more second-line drug, then verapamil is safe. And again, you can give up to 10 milligrams without even thinking about looking at the fetal heart rate. And you can give more after that, but just we would recommend that you just monitor the fetal heart rate. Also, flecainide and propafenone can both be used, but again, they tend to be used predominantly in the cardiology setting. So what about fib and flutter? They're very uncommon in pregnancy. And if they are, you've really got to think about whether that woman's got structural heart disease. Again, they're often reasonably well tolerated unless you've got severe mitral stenosis, in which case they're very badly tolerated. And again, that's when the beta blockers come in. It is really important to terminate the arrhythmia because what you don't want is the need for anticoagulation. So outside of pregnancy, we would say if you've been in the arrhythmia much more than 24 to 48 hours, you must be anticoagulated for at least 4 to 6 weeks. Before you even contemplate cardioversion because of the risk of thrombus formation and therefore stroke should you cardiovert them chemically or electrically. And obviously in pregnancy, it's a prothrombotic state, but so no one really knows how many hours you can be in safely, but we would say certainly if you've been in it 24 hours, I'd be unkeen to cardiovert. You're in a sort of slightly ticky, I'd probably do a TOE guided cardioversion at that state. So to try and avoid the need for cardioversion, I always get my team to use to look at AF in pregnancy as a medical emergency. Let's get the patient out of it, and then that worry about long-term anticoagulation in the pregnant woman is omitted. Again, if you have to just slow them down, you can use flecainide and sotalol to cardiovert them as well as standard DC cardioversion, but if you need to rate control them, verapamil, digoxin, and other beta blockers are absolutely fine. So cardioversion is well tolerated, it's effective, we can do it at any stage in pregnancy, and the effects on the fetus are really quite minimal. So people always worry, but it's really not a problem. The only problem is that beyond around 12 weeks, you really probably need to get an obstetric anaesthetist because you need to intubate the woman rather than just do what we do in the normal cath lab, which is, give a bit of midazolam shock and, and sit them back up. So that's the only problem, is that because the delayed gastric emptying, you probably need to do a full intubation. So you do need to be doing it with anesthetic support. Ventricular arrhythmias, you'd be delighted to know, are rare. The most common arrhythmia is right ventricular outflow tract tachycardia. So in other words, a VT in the structurally normal heart, and that responds really well to beta blockers. And if not, you can try verapamil. So some of them are calcium channel sensitive, some of them beta blocker sensitive. If you've got the sort of monomorphic VT, the one that's quite bad, then IV lignocaine can be used and is very safe in pregnancy. And I've put amiodarone there. So people say, oh, you can't use amiodarone in pregnancy. I wouldn't recommend amiodarone long time through the whole pregnancy. But if you've got a woman in VT who's poorly, you don't want to be messing around. Get that woman out of VT, either with cardioversion or give her amiodarone. The worst case scenario, the baby gets 1 or 2 doses. We can manage that thyroid dysfunction afterwards. ICDs, we're using these an awful lot, and it is important to have a full plan for ICDs, both through the pregnancy and at the time of delivery. We have a magnet on labour wards, so if you need an emergency section, you can tape it to the ICD and it just disarms it. So you can just get on, do your section, and then take it off. If the woman goes into VT during the delivery, either delivery or section, you just take the sellotape off, and within a minute it's armed itself and will shock. And obviously, if you're doing elective section, then you can use your cardiac physiologist. Please be aware it's a proper high-grade, very heavy medical magnet. I have seen people in emergency try and use fridge magnets. It will not work. Cardiac arrest is rare, and you need to obviously be aware that if you're doing a cesarean section, you're doing it to aid the resuscitation of the mother, not to save the baby. If you've got one of the Lucas devices to do CPR, then I would recommend it, because it's quite hard to do CPR in a pregnant woman due to the enlarged breast and diaphragmatic splinting. So in summary, heart disease in pregnancy remains the UK largest cause of maternal death. I've tried to gallop you through the acute emergencies of cardiology in pregnancy. I think if in doubt, you do what you would do if the patient wasn't pregnant, and also phone a friend. Okay, there are many of us that are involved, and we are more than happy to be contacted about these patients. So just to say thank you very much for the invite, and I'll take any questions.
Thank you, Dawn, for this excellent comprehensive cover of a very difficult subject. And as I said earlier, I think cardiac disease is a problem in Jordan. It's the commonest cause of indirect maternal mortality in Jordan. I have a couple of questions for you. I mean, you've touched on arrhythmias and SVTs. Did you have to do any ablations during pregnancy? I mean, would you consider doing an ablation during pregnancy?
I wouldn't. And the reason being is you can do it. They're now increasing stereotactic techniques. That means you don't really need to use radiation. But to be honest, apart from one patient with an atrial tachycardia, which was quite difficult to manage with medical, with pharmacology, she was one that I got very close to thinking I was going to have to do an ablation. But all my other patients I've managed to manage medically, and then I do the ablation afterwards. And I think you get much better success, and it's a lot less stressful. Okay.
And you touched on aortic dissection. I mean, from the medical legal point of view, what's the time frame that you have to diagnose aortic dissection if you want to make sure that you're not going to lose a woman in the AR or whatever? I mean, you've mentioned CT scans. I mean, we have CT scans here in our emergency departments, in the big emergency. It's about thinking about it. That's the problem. So what?
No, you're absolutely right. Every hour that goes by, the mortality increases significantly. And actually, I was on a recent webinar with a vascular surgeon, and they showed the data to the time taken to diagnose a dissection in the pregnant and the non-pregnant woman. And it's far, far longer in the pregnant woman. And so you're absolutely right. It's about having a low index of suspicion and then not being frightened to put them into the CT scanner to get that diagnosis. There are lots of things we can do now with collimation and scout views to minimize the amount of radiation. And actually, when you measure the amount of radiation, it is actually really quite minimal. You'll be quite surprised with the modern day scanners. So every minute that goes past increases the risk. They say the golden hour, that you try and get it done as soon as possible. So yeah, I would just say, just don't be afraid. Have a low index of suspicion, and then if in doubt, scan. No one will ever medico-legally sue you for doing that.
Sure. I have a question from Bayar Najat. Is it a guideline to deliver the baby by C-section during arrest or post-mortem, and in what time limit?
Okay, so we have UK resuscitation guidelines, and in the pregnant woman, after 20 weeks, it is our guideline to consider a perimortem section. And the reason is to aid resuscitation of the woman because of the improved venous return. So that's in our UK resuscitation guidelines.
And the time limit is, you agree with 4 minutes, isn't it? Unfailed resuscitation. Is this?
So yeah, I mean, we say that, but by the time you've got anybody there to actually do it, I think it's really, as soon as you can get an obstetrician there, it's make that decision. The thing is what I said to the team when I had it is, this woman is arrested, so you've lost her. So the only thing you can do is get her back, and just anything that you can do is important.
Okay,
but it's a very traumatic thing to do.
Abir, you want to ask a question?
Yes, please, Dr. Dawn. If we have a dissecting aneurysm in a pregnant lady who is 18 weeks pregnant and she's to go for surgery, would you advise termination of her pregnancy before you go for the surgery? And
No.
I'll tell you why. We had a patient that she had a dissecting aneurysm, and she went through the surgery, and it was successful surgery. And when the baby was born, he was asphyxiated, and he lived for 12 years vegetative although the fetal heart was monitored during the process. So I would like to hear your opinion about it.
Okay, so I think when you're looking at aortic dissection surgery, you're looking at literally every hour counting. So one of the problems is below 18 weeks, the the baby is not. We don't want to delay the time. So the only reason we would say deliver the baby normally is because actually it's impairing the venous return, and it's impairing the surgeon actually being able to operate because there's a big bump in the way. Whereas below, 20, 24 weeks, then we would advocate, leaving alone, and the baby needs to take its chance. But it's a really complex decision. We in the UK would probably leave the baby in situ and then try and make some decisions afterwards, depending on baby's success. But I think what you've got to do is remind that lady that actually there's a very high chance that she won't survive. So if she's survived long enough to be fighting you over a legal case, actually I would call that a success. But I appreciate medico-legally that's a difficult situation.
Mm-hmm. Yeah.
Okay. What about counseling regarding termination of pregnancy in patients who are pregnant with severe cardiac problems, that you're worried that they might die basically if they continue?
Yeah, I've had to do that an awful lot. And in fact, Lucy and I shared a case of a woman that we counselled extremely strongly to terminate, and she refused, and actually she delivered a baby and died 3 days later. And yeah, we won't forget those cases. So I think what I do is try and see these women as soon as I can. So I have a system where I get to see them 6-8 weeks of booking. So the earlier you can see them, the better. And then it's about talking through them about the risks, making sure that both the patient and their partner is fully aware of the risks. And I'm very clear. I say, there is an X risk of chance of you dying. And then it's about sort of saying to the partner, are you ready to look after the child on your own? So we make it really, really sadly quite clear, because I think these are really difficult decisions, and what you want is that couple to go away and have no doubt in their mind that there is a significant chance of mortality. So and I use the word death. And then it's about bringing them back, making sure they fully understand. I ask them to, talk to me about what their understanding is. I obviously try and put it in a letter as well, so they've got a chance to read it. Tend to bring them back at 10 and again at 12 weeks or 10, 12, try and bring them back as much as you can. And then there gets to be a point where you think, right, we fully discussed it. I am very happy that the couple and whoever, if they want to bring as many family as they want, I don't mind, as long as whatever the couple want to do, I support them. Once I know that the couple are fully clear on the risks, and despite knowing their risks of death, they've decided as a couple to continue the pregnancy, and it's all fully documented, then the next thing I tell them is, and I tell them throughout, that if you decide to continue the pregnancy, please know that I will fully support you. I won't be cross. I won't be angry. So don't be afraid, because we have had, I know of a case in another unit where they cancelled the patient, and then the patient went AWOL because they were frightened to come back to the team because they thought they'd be cross because they've not taken their advice. And that's the last thing you want, because if you are going to have any chance of keeping that woman alive, it's because you're going to be monitoring her and looking after her very, very closely. So I make that point very clear, that if you make that decision, then I will respect that decision. It may not be my decision, but I will respect that decision and support you fully and look after you through the whole of the pregnancy. And that way you've got full engagement.
Well, that's excellent. Thank you.
I have one more question.
Yeah.
I want to ask your experience during, cardiac version or cardioversion during pregnancy. Has anybody studied the changes on the fetal heart tracing? I know everybody will be busy, doing the cardioversion in these emergencies, but did anybody notice any changes on the fetal heart tracing during the cardioversion? Do you have an experience with that?
Okay, so I don't actually monitor I monitor the baby beforehand with either a CTG or a sonic aid and make sure we've got good fetal heart. I then cardiovert the patient, and then we check afterwards. we don't tend to do the CTG during cardioversion. And the other thing that I didn't mention is I also do the pads AP. So I don't put the pads in the top shoulder and two across the chest. I put one at the front and one at the back.
Mm-hmm.
Okay. But no, I'm not aware of that, because I don't think, the thing is the problem with measuring any change in fetal heart rate on CTG during cardioversion is you then don't know what to do with what you see. And actually, the data that we've got is there's been that the only theoretical risk is that of premature labour. And actually, the only time that I've seen or heard about that, the woman had a high chance of going into premature labour from her underlying condition anyway. So I'm not convinced it was a cardioversion.
Thank you.
Thank you very much, Dawn, for an excellent talk, and we hope to see you soon in person in Jordan. Thank you very much.
I love that. Thank you. Thank you, everybody.
Thank you, Dr. Lucy. Thank you very much.
Our next speaker is Lucy McKillop. She's a consultant obstetrics physician at Oxford University Hospitals NHS Foundation Trust. She's also an honorary senior clinical lecturer at Nuffield Department of Women's and Reproductive Health, University of Oxford. Lucy is going to talk to us about connective tissue disease in pregnancy, a very important subject. So the floor is yours, Lucy.
Thank you very much. Sorry, I'm already having technical problems, but I'll be 2 seconds. It won't let me share now. Can you see that at all?
Not yet.
Not yet. Not yet.
Okay, let me try again. Apologies.
No worries. No worries. Take your time.
So that works.
Yes, we can see it now.
There we go. Okay, great. Well, thank you very much for inviting me to talk today. So I'm going to talk about pregnancy and connective tissue disease. And this is a non-exhaustive list of some of the common rheumatological conditions that we will see in our antenatal clinics. And the reason that we're talking about it today is because there is a female preponderance in these sort of conditions. It does affect women of reproductive years. And with better disease control and changes in our social views about pregnancy, more women are desiring pregnancy who have long-term, long-standing rheumatological conditions. Therefore, we need to know about it. And it would be a very boring talk if I just went through all the different medications that are out there that are used for rheumatological and connective tissue disorders and told you which were safe and which were not. So I'm not going to do that. And also, of course, there aren't huge amounts of randomized controlled trials to tell us definitively one or the other. So often this is a risk-benefit ratio that we have to discuss with the woman, make sure that she's comfortable in her choices, and then support her choices. When you're seeing a woman with a connective tissue disease, of course, it's best to see her preconceptually. Although often I get referred these women primarily to discuss the medications they're on, in fact, you can see here, this is at the bottom of my list, and there are much more important things to discuss first. So we need to understand what her disease is and the activity and the history of disease. Is she very inflammatory, or has she got burnt out rheumatoid arthritis? We need to understand her beliefs and wishes and her current knowledge. And then we need to explain very clearly the effects of the disease on her pregnancy and whether the pregnancy can affect her disease. And then we need to make a prospective management plan that will cover her antenatal, intrapartum, and postnatal management. And of course, drugs comes into that, but it's only very much a part of that. It certainly isn't the main part of that. And I'd like to illustrate my sort of thoughts with a couple of cases today. So they're both real cases. This is the first case of a 34-year-old primary school teacher who I saw for pre-pregnancy counselling, and she'd been referred by her fertility team. She had rheumatoid arthritis and she'd had subfertility for 18 months. She gave a history of her arthritis starting 8 years previously. She had a combination of small and large articular manifestations of her rheumatoid, and she'd been relatively well controlled on a combination of methotrexate and leflunomide, but she'd sought pre-pregnancy counselling, and these are contraindicated in pregnancy, so these were appropriately stopped some 2 years before in anticipation of a pregnancy, and she was then put on sulfasalazine, but it really wasn't as effective. So when she was seen just before I saw her, she had very active disease. She was on some hydroxychloroquine, she was on depomedrone, she was on some diclofenac and folic acid. And at the time, it was a few years ago, they were considering a biologic, but they were concerned about the safety data around biologics, so that they were not imminently going to start on a biologic. So when I just saw her, her disease was not very well controlled at all. She was on sick leave because of tiredness, immobility and pain. She felt the hydroxychloroquine might help a bit, but the depomedrone really only lasted, the effect lasted less than 2 weeks. So we need to discuss her subfertility and what's going to happen. We need to discuss the medications that are best for her in pregnancy, and the implications of the pregnancy on the disease, and the implications of the disease on her pregnancy. So very briefly, there is data out there to suggest that those people with rheumatoid arthritis and other connective tissue disorders are less fertile, as there are higher rates of artificial reproductive techniques. And there's probably a multifactorial reason for that. There'll be some physical disability and joint stiffness. There may be diminished libido related to long-term chronic illness. There's fear from the woman about the potential side effects of the medication, and possibly that of a physician as well. We also know that non-steroidal anti-inflammatory drugs can lead to unruptured follicle syndrome, and therefore subfertility that way. And often, and maybe in the past more so, many of these women had been counselled since, if they'd had juvenile idiopathic arthritis, they might have been counselled since childhood that they shouldn't ever conceive. So it was quite easy, really, to counsel this lady about starting a biologic. We knew that her fertility tests were going to take a little while. She was going to be less likely to conceive with active disease, and she was completely miserable and on sick leave. So we were able to counsel her appropriately about that, and we were going to monitor the effects, and she was going to continue her fertility treatment, and then we were going to make a plan after we'd seen whether she responded well. So she'll need a fertility workup. As I said, if we can get her better on her biologics, we can take her off her non-steroidals, which in itself might help her fertility. And the other important thing is, when we're counselling women for pre-pregnancy counselling who are going for fertility, it's very important to say to them to have a single embryo transfer rather than a double embryo transfer. As we all know, all pregnancy complications are increased in twin pregnancy, and her disease puts her at high risk anyway. So the current teaching is that there is a sort of a shift from T1 dominance to T2 dominance, a humoral dominance in pregnancy in terms of the immune system. And we're taught that actually rheumatoid arthritis should get better in pregnancy. But in fact, many of the prospective studies in the UK and the Netherlands don't show that, actually, with less than 25% of women actually getting better. And you're less likely to have any remission of your disease if you're anti-CCP or rheumatoid factor positive. And it's very important also when you're counselling women to talk about the extra articular manifestations. So rheumatoid arthritis can affect the lungs, it can affect the heart and the cardiovascular system, and pulmonary hypertension in particular is associated with rheumatoid arthritis and has a very high mortality rate in and around pregnancy, as Dawn has already alluded to today. As to obstetric outcomes, it's important that we counsel her about that. This is a systematic review and meta-analysis showing that actually overall women with rheumatoid arthritis do well, but they are more likely to statistically have a preterm birth, and that was mostly related to preeclampsia. The study below that I've written here, this looked at women with severe rheumatoid arthritis, and their indication of severe was they'd had an orthopedic surgery because of their rheumatoid. So they was the severe end of the spectrum, and this was a prospective study from Scandinavia, and showed that there was a statistically significant increased risk of preterm birth and small for gestational age. And certainly it is my usual practice for women, unless they've got very mild disease off treatment, to give them aspirin for preeclampsia prophylaxis in pregnancy. So for this lady, we continued hydroxychloroquine, we increased her folic acid, we gave her some aspirin, she continued her depomedrone, and we weaned her off her non-steroidals, and we had her on her biologics, and then we decided we were going to talk a bit later about whether she needs to stop a biologic later on in pregnancy or not. But again, it's not just about the drugs. It's important to have increased contact with these women, both for their physicians and their obstetricians, and co-management and very good communication between all of the healthcare providers providing care for the women, so they feel comfortable and confident in their pregnancy and the management choices. So just a brief thing about biologics. Again, essentially, the issue with biologics is that they are a big molecule and they don't tend to cross the placenta in big amounts until the 3rd trimester. So we've had data now, really quite strong data, to suggest that there's very little or no transplacental passage in the 1st trimester. So therefore, it makes sense that birth defects and congenital malformations are not increased because of the drug in this group. However, these big IgG antibodies do cross the placenta preferentially in the 3rd trimester, as the active transport of antibodies, maternal antibodies, to the fetus happens for all other antibodies, and they just use the same mechanism. And so the degree to which these biologics will cross the placenta will depend on their half-life, and it will depend on their structure. And so we do know that medications like infliximab avidly cross the placenta, less so etanercept, and it's got a shorter half-life, so you can stop it later if you want the baby to not have any of the medication in its system at the time of birth. And then there are medications like certolizumab pegol, which is used often in the spondyloarthropathy, so ankylosing spondylitis and things like that. And that's actually licensed for use in pregnancy in the UK now. And because of its structure, very, very small amounts of it cross the placenta just by normal diffusion. So it is safe to use in pregnancy. So we've got more data as these biologics get used, in more conditions. It's used more in all pregnant women, but obviously as the data accumulates over time. So this is a very helpful slide that was actually from the review that is referenced here, and shows the half-life and the percentage in cord blood of these the most common biologics, and then the suggested time to discontinue if you want to make sure that the baby has no or very little drug in the system at the time of birth. And why do we worry about that? Well, I mean, there's very little evidence to suggest that there's major issues with the baby born of a mother who's taken biologics throughout the pregnancy. So they're born with, 10 fingers, 10 toes. We know that the congenital malformation risk is not higher. They tend to have normal blood count, with the exception potentially of rituximab, which may deplete the beta cells function of the baby. And they seem to respond normally to the normal vaccination protocol. And this is the vaccination protocol we have in the UK. There are not very well conducted studies that suggest that they may have slightly more increased risk of infections in the 1st year of life, but that was a retrospective analysis where women were rung up and asked whether their baby was ill in the 1st years of life, and so it wasn't a very well conducted study. And the only exception to the vaccine issue is for live vaccines. So when infliximab was first licensed for use outside pregnancy, they were given to people, and it was noted that there was reactivation of latent TB in this group, which has led to the usual practice of, before someone's given infliximab, they have a MAN2 or an IGRA test to check that they don't have latent TB, and they're treated if they do before they start treatment. We didn't think about this in these women getting pregnant, and actually there have been a couple of case reports of babies dying of BCG vaccination when they had been given it in a baby of a mother who'd taken infliximab throughout the pregnancy. So it is our normal practice in the UK not to give live vaccines, which in practice is just the BCG vaccination and the rotavirus, but all the other ones that I've got here are until we get to the MMR, which is at 12 to 13 months, years of age, and that's out of the window of when we need to worry anyway. And again, it's important to think about other, obvious things, but it's important to make sure that's in your management plan. So we need to make sure we consider her thrombotic risk. If she's very inflammatory, she may be, or immobile because of her arthropathy, she may need thromboprophylaxis. If she's got a problem with the spine related to rheumatoid arthritis, it's important she sees an anaesthetist early on, just in case they need to do a GA section. We need to think about bone health. Many of these women are osteopenic, either because they've been on steroids for long term, or the chronic disease has led to osteopenia. And likewise, many of these women are anemic and therefore need to have extra iron. We've got to think about the care intrapartum, make sure there's care in lithotomy for women who've got their hips affected, and we need to be consistent about breastfeeding advice. So, for example, biologics are fine to give in the breastfeeding woman, and the woman can breastfeed on those. And likewise, most of the medications that we would use in someone with connective tissue disorder. But it's important that the advice is consistent so the women feel supported. And again, some of these conditions, like rheumatoid, can often flare in the postpartum period, so it's very important to make sure that we have a physician follow-up soon after delivery. And the vast majority of women with well-controlled arthropathies will have a very successful pregnancy. And I think that's very important to put as well. But remember, we need to remember the non-disease modifying medications too. And usually the first line of treatment for an acute flare of these arthropathies will be steroids. So I've got a second case now. This is a 40-year-old woman with no past medical history who had a normal antenatal course up to 30 weeks. And then she got some itching of her palms and soles of her feet, and she was found to have a raised transaminitis, raised bile acids, and she was started on ursodeoxycholic acid for presumed intrahepatic cholestasis of pregnancy. Her LFTs normalized and her bile acids remained around the 40 to 50 mark. And at 39 weeks, she was seen by a consultant in clinic. There was noted to have a fetal bradycardia. She was sent straight to the delivery suite and had a Cap1 cesarean section, but unfortunately her 3.1 kilo baby was stillborn. There was a note on at the time of birth that there was meconium stain glycol, and nil else was found on post-mortem. 8 weeks after the birth of her baby, she developed joint pains, rash, fever, profound lethargy, and she had an active urinary sediment. So she had casts, red cell casts, white cell casts, and protein in the urine. And her creatinine went up to 300 micromoles per litre. And she had a renal biopsy, which showed she had a class 1 lupus nephritis, and her antibodies came back suggested very much of lupus, ANA positive, double-stranded DNA positive, anti-Rho, anti-LAR positive, anti-cardiolipin antibody positive. She was given methylpred pulsed, followed by cyclophosphamide, and then she was on maintenance azathioprine, prednisolone, and hydroxychloroquine, along with ramipril to aid her renal recovery, and she made an excellent recovery. And actually, I saw her the first time in 2010 for pre-pregnancy counselling. So at this point, she had normal blood pressure, she had nothing in her urine, her creatinine was back down to normal, and she had no symptoms. So what do we counsel her about? Clearly, she has a potential increased risk of recurrence of her intrahepatic cholestasis of pregnancy, and of course she has a risk of associated new risk of that of lupus. So what do we need to think about when we think about lupus? Well, lupus can be a very broad diagnosis. It can be anything from a sort of discoid lupus rash, which really has very little problems in pregnancy, right the way through to florid systemic lupus erythematosus. And if you've got cardiac, lung, or cerebral involvement or renal involvement, really your risk in pregnancy is much, much higher. There are also specific antibodies that are associated with poorer outcome, that of anti-Rho and anti-LAR antibodies and antiphospholipid antibodies. And we know that as far as anti-Rho, anti-LAR antibodies are concerned, around 30% of women with lupus will have these antibodies, but they're associated with other connective tissue diseases. It's not just lupus. So often people will present just with Raynaud's or Sjögren's syndrome, and they won't have the rest of the lupus, but they will still have these antibodies. But it's important that we check these antibodies. Interestingly, if you have a baby who has congenital heart block, 50% of the women will have some sort of connective tissue disease within 15 years, even if they hadn't been diagnosed with it before. And the risk with anti-Rho and anti-LAR antibodies are that of neonatal cutaneous lupus, which is shown here on the right, in 5% of babies, and congenital heart block in 2% of babies. This lady, second case, she was 42 by the time she conceived. She had normal blood pressure, normal urine, weight was okay. She was on these medications. And at 23 weeks, we noticed she had secondary heart block of this baby. And so she was followed up fortnightly for the rest of the pregnancy. She had no obstetric cholestasis this time and had an elective cesarean section at 38 weeks. And the babies actually did very well and was under cardiology review. And her lupus was quiet throughout the pregnancy and postnatally. But it does beg the question about whether that stillbirth was actually related to intrahepatic cholestasis of pregnancy, or whether actually that was a congenital heart block baby that hadn't been picked up before because she didn't have any symptoms and led to a stillbirth. Just the last two slides I have just about the data regarding hydroxychloroquine. So a few years ago now, there was some retrospective data published on 3 databases in the US, UK and France. And they looked at mothers with lupus who were anti-Ro, anti-LAR positive and who had had a baby with congenital heart block. And they noted that those people that were on hydroxychloroquine from before 10 weeks pregnant were much less likely to have a second child affected with congenital heart block. And you can see the data there. More recently, there's been a prospective trial, but it's single arm still, but they took 54 women who were anti-Ro, anti-LAR positive, who had had a previously affected baby and gave them 400 milligrams of hydroxychloroquine before 10 weeks. And they had a very low incidence of congenital heart block compared to previous data. So that does suggest that hydroxychloroquine should be used for secondary prevention of congenital heart block, but there's no evidence yet for primary prevention. So if a woman pitches up, she has a baby who's never been affected, or she's never been pregnant before and she's anti-Ro, anti-LAR positive, it is still not my practice to start hydroxychloroquine on her unless there's another reason for doing it. I wouldn't do it just from the point of view of her anti-Ro, anti-LAR antibodies. So in conclusion, aim for disease control in pregnancy-friendly medications, check for antibodies like ENAs. Remember, aspirin, these women are at increased risk of preeclampsia, more contacts, not less. Treat flares aggressively. Prednisolone is our usual first line. Remember the other complications: gestational diabetes, hypertension, VTE risk, anaesthetic risk, and remember her bone health. And remember good communication between all the healthcare professionals and good care during labour. Encourage breastfeeding as you would with anybody else, and make sure she has follow-up with her physician postnatally. Thank you very much.
Thank you, Lucy, for this excellent practical talk covering the subject. I want to ask you about biologics. What percentage of your patients are on biologics, and do they take them for life, or you start and stop and start and stop?
Yeah, so biologics are used for a number of conditions now, and obviously initially it was more for connective tissue and rheumatological conditions, but inflammatory bowel disease is more common than these conditions, so I tend to see more women on biologics for that reason, but also hematological cancers, allergy, I mean all sorts of dermatological conditions. There's all sorts of reasons for using biologics these days. And you know, it is my observation that many women will require a number of different biologics during their lifetime. So they may not always respond. They might have years of responding to one and then will need to be swapped over to another. But I wouldn't normally swap them over, particularly for pregnancy. So if they are, I don't know, receiving pre-pregnancy counselling, they need to have a biologic for their spondyloarthropathy. I will suggest, of course, they have pegylated sertolizumab pegol, because that is probably best in pregnancy. But if they're already on something else, I wouldn't change them.
Okay, and are there any cases where you advise against pregnancy in these pre-counseling clinics? Any of those ladies, any of those patients with connective tissue disease that you would advise them strongly against pregnancy?
I mean, really, it is in that one slide that I showed you about, so for women with significant cardiorespiratory disease related to their connective tissue disease, so they've got really horrible interstitial lung disease, or they've got pulmonary hypertension as part of scleroderma or a nasty rheumatoid lung, then you know, they are at very high risk. I rarely say, no, you must not have a baby, but I will say your mortality rate is 1 in 4, and usually women will agree that that is high and that they shouldn't go ahead with the pregnancy. I think the other point is for the women who've had really nasty thrombotic events, or so catastrophic sort of APS or stroke related to antiphospholipid syndrome, where we're going to have to anticoagulate them and potentially use warfarin rather than heparin. We need to discuss that and say, well, if you're going to have a pregnancy, we might have to manage it on warfarin and accept that there's a high chance of fetal loss because your risk is so high. So there's those sort of conversations to have. I don't tend to say no. I just tend to give them the information that we have based on the studies.
And if during pregnancy you picked up anti-Ro, anti-La, and there is evidence of heart block in the fetus, how would you manage those pregnancies in terms of treatment?
So there's
a difficult area.
I mean, this is more fetal medicine than maternal medicine, but there are some studies that suggest that steroids or IVIG may affect the prognosis, particularly if you pick up a baby with second-degree heart block and try and prevent them getting to third-degree heart block. But the evidence is not fabulous for that. So I would leave that sort of thing to the fetal medicine specialist, really. But those are the medications and management that have been tried before.
Okay, Abir and Dr. Mazen, do you have any questions? Dr. Abir?
Yes, please. Lucy, thank you very much for the very nice comprehensive presentation and the case that you have shared with us. And my question now will be, that you agree that the biological now doesn't have to be stopped at 32, at 34 weeks. By the time, we have studied this before, and now most of the studies are saying that you can go ahead with your biological use till the end of your pregnancy. So you agree with this one, right?
Yes, I mean, the guidelines still suggest that you should consider it. And I would agree that there's no compelling reason to stop it, except that we just don't have data on these children in 10 or 20 years' time yet, because it hasn't been around enough. So we don't know whether there's any long-term immunological impact on a fetus or not. So certainly if the woman needs it for disease control, absolutely. But if a woman has good disease control and has done for years and feels that she can miss a couple of doses at the end of the pregnancy, it's still reasonable to do that.
And most of the pharmaceuticals will advise with the biological agents not to breastfeed, although the levels are very low in the breast milk and it's safe to use them. Although most of the manufacturer and pharmaceuticals say don't breastfeed, they don't want to take the responsibility of breastfeeding with the biological use. So I would like to hear your opinion about that.
Yeah, well, that's the same for most drugs, isn't it? In pregnancy, they were unkeen to advocate it. But you're absolutely right. These biologics almost entirely are given by infusion because they're denatured in the gut, and therefore it makes sense that if there's very little that gets into the breast milk, but a bit does, but then it's got to go into the baby's gut and it will be denatured there. So actually, any systemic absorption is tiny, 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 and therefore breastfeeding with these biologics is absolutely fine.
Yeah, thank you very much.
You. Dr. Mazen, do you have any questions?
Yeah, thank you, Lucy, for this excellent lecture. I know lupus have a risk of thrombosis and vascular thromboembolic phenomena during pregnancy. These patients to be put on low molecular weight heparin or not?
So it very much depends on their previous history. Obviously, clearly, if they've had any clots beforehand, yes, absolutely, I would. If they're on long-term anticoagulation, I have them on therapeutic dose, not just prophylaxis. But if a woman is systemically well, she has no evidence of systemic inflammatory response, her CRP is low, she feels well, and she hasn't got any other risk factors, then I wouldn't automatically put her on low molecular heparin, but I would have her on aspirin.
And after delivery, do you think it is needed?
Yes, I mean, again,
for the perdural period.
Yes, our sort of national guidelines would suggest that you need 2 risk factors in order to get low molecular heparin for at least 10 days, and I wouldn't count her disease if it's very quiet.
Okay, thank you very much.
I have a question here. Shall rheumatoid arthritis patient remain on the same dose of steroids, or they should decrease the dose?
It's a good question. I guess So some of the literature would suggest that we should be trying to aim for a prednisolone less than 15 milligrams. And I think, regardless, and that's actually generated from old data about the fetus, which is not very good quality data. The reason for coming down off the steroids, if you possibly can, is because of the increased risk of hypertension and gestational diabetes, which of course will complicate the pregnancy as well. So if a woman, particularly if she's got rheumatoid, is very, very well, we can consider dropping it down very, very slowly, literally sort of a milligram, a week or something down to a lower dose. But it's not something I do all the time. Often I just keep them on exactly what they are on, because what I want is their disease to stay controlled.
Okay, Lucy, thank you very much for this excellent talk, and we hope to see you in person in Jordan soon after the COVID era.
Absolutely. Thank you very much for inviting me.
Thank you.
Thank you.
You're welcome. I will pass to my friend, Dr. Mazen Al-Zibda, now to introduce the next speaker. Dr. Mazen.
Thank you, Maher, and thanks for the speakers. It's my pleasure to introduce to you the next speaker, Dr. Charlotte Fries. Charlotte Fries is a consultant physician in general medicine and obstetric medicine. She is based at John Radcliffe Hospital in Oxford. Also, she works as a consultant obstetric physician at Queen Charlotte and Chelsea Hospital in London. Dr. Fries has published many articles and numerous book chapters and articles. Recently, she has written Obstetric Medicine in the Oxford Specialist Handbook of Obstetrics and Gynecology series. Dr. Fries is a senior college lecturer and in clinical medicine at Keble College at the University of Oxford. Also, she is a co-author in the International Journal of Obstetric Medicine. I think her topic is awaited for a long time, and we have been suffering for the last 18 months with a lot of questions and a lot of patients who have faced the pandemic of COVID-19. We are going to listen from her about her COVID-19 experience in Oxford and maybe in UK. Thank you, Dr. Fries, and the floor is yours. Please, Dr. Fries.
Great. Thank you very much for your very kind introduction and for inviting me to speak. I'm hoping that you'll see my first slide, not my end slide. Can you see my slides okay?
Yeah, we do.
Brilliant. Okay. So in contrast to the two previous talks, which I greatly enjoyed listening to, I'm going to solely focus on one condition, and I'm going to base all of my discussion about it on what we experience locally, because I think that there are things that we can learn from the way different centres handled things. And I wouldn't want to generalise and assume that every healthcare system, nationally or internationally, was able to deliver exactly the same model of care. You'll hear me talk about the practicalities and problems that we encountered, but also the way we solved them at a local level. And I'm also going to touch on vaccination and the importance of vaccination in the future of this condition and how we manage this, particularly with relation to pregnancy. So in the first wave, Oxford was relatively protected. So we were behind London in the spread of cases. We're at least a fortnight behind. And when our Prime Minister Boris Johnson announced that pregnant women should stay at home, this was at least a week or so before the national lockdown guidance that we were given on March the 23rd. And at that time, we only had reassuring data from China coming out about the effects of COVID in pregnancy. And we were obviously worried because we know that some viruses, particularly the influenza we'd seen in the last epidemic, was more severe in pregnancy. So there was a great fear about the effects of COVID. But I think I was not alone in being a bit surprised at that pre-lockdown guidance for pregnant women, because I really couldn't see what it was based on. But actually, in retrospect, that was hugely protective for our population, certainly in our region, because the cases had not spread to our area yet. And by the time they did, pregnant women were very protected. They were staying at home, and shortly after that were followed by their partners and their children in the national lockdown. So this resulted in very few cases being admitted to hospital. Now, I'll show you the numbers here to compare to. So these are numbers of cases that we know about. And I think it should be stressed that this, of course, is a massive underestimate. A lot of people weren't being tested. Universal testing was not available in the UK in this part of the pandemic. And we certainly didn't have a robust way of discovering those positive women who did not come to the hospital. We would discover them, but through roundabout ways. Maybe they'd been flagged to a hospital consultant and we heard about them. So whilst the numbers are there and quoted, I want, there's a big caution about the interpretation of those absolute numbers. So it's not a surprise to see that when we compare that to a period later in the year, the numbers were of entirely different magnitude. And whilst we were better at flagging our cases in the community, and we obviously knew about the ones who were admitted, of which were much greater in number, again, we were limited by communication initially. I'll show you later how we dealt with that, by community cases. So I'm certain that there were a lot more community positive cases that we never heard about. But these are the numbers of everyone who came onto our radar. And this was helped by the fact that by this point in the pandemic, we were doing routine PCR screening on everyone admitted to a maternity setting. And so we knew about a lot of asymptomatic but positive women. We also quite quickly set up a COVID team, and we made sure that we were reviewing the inpatient records to flag, to make sure we highlighted to our team anybody who was COVID positive who may not have been actively flagged by their healthcare professional. And we also had a central coordination of our COVID response, which helps to bring this all together, and I'll talk a bit more about. So there was a pretty even split between trimesters of pregnancy. However, there was, when you see the second and third trimester represented there, actually, I think if we did it by weeks of gestation, the pattern would be very different. And most of the women in the second and third trimester, this was not a spread from 12 weeks to 39 weeks. This was a spread from about 25 weeks to 35 weeks. So actually probably a narrower risky period than is represented on this distribution. And if we then look at the ethnic background of our patients, again, it was not a surprise to us and in line with other data that there was a predominance of infection in women of Black and minority ethnic background. Now, when we compared this to nationally available data, there are some similarities and some differences. So the UK Obstetric Surveillance Survey published their results about mainly in the first wave. So again, remembering the numbers I showed you, they're not directly comparable because we're comparing OUH's latter half of the year data with UCOS, which is slightly earlier in the year. But the patterns were similar. So there was a predominance and a risk of a greater admission, a predominance for overweight or obese women, and they were again predominant in the late second and third trimester, and that ethnic background predominance that I already told you about. The striking thing that differs here is the need for significant respiratory support, and so the 90% of our women who were admitted were needing respiratory support, but again the population is difficult to compare directly. So if we then talk about our setup in a practical sense, well, what were the issues we encountered? Well, our Women's Centre and the entire maternity service is in a separate building to the main John Radcliffe Hospital, where all of the medical wards and the intensive care support are. Whilst we have a number of areas of all our wards that have piped oxygen, this certainly is the minority of bays because it simply isn't required for the majority of women in maternity. There are not many medical teams who have to come to maternity. They are not familiar with the geography of it. I suspect they couldn't even make it, into a specific ward without needing assistance, and I certainly don't think they all have routine access to it. But what felt most pertinent was the distance from both radiology, but also the physical areas of adult intensive care and respiratory support, but more importantly, from where the clinicians were based if you needed them in a hurry. So we had many conversations about how we could mitigate these risks, and a number of important things that we set up quite early on was we created a nominal COVID team. It wasn't a big team. I don't want you to think it was dramatic and a huge number of people, but that was based through our high-risk maternal medicine team, but with help from some trainees who were working from home who were able to take on some of the more practical aspects that they could do in that way. We quite quickly set up a meeting. It was 5 minutes long to 10 minutes long every day of the week, because what we noticed is that actually these women can be in all sorts of different settings in the hospital, and actually to coordinate a safe and timely response, everyone involved in the on-calls that day, both from a midwifery, from an administrative and a medical perspective, needed to know about the women, how sick they were, and what the current issues were. We also set up an obstetric arm of a service called COVID Care at Home, which was a big service set up by our ambulatory medical colleagues to look after people who were in that 14-day risk period of respiratory deterioration, but did not warrant hospital admission. And these people were sent home with oxygen saturation monitors, and they were phoned daily by one of the ambulatory nurses. Again, it became quickly clear that that was very useful for a small number of our pregnant women, but the ambulatory nurses weren't the right people to do that. So we set up an allied but separate service involving our obstetric trainees working from home, because quite often these women had quite complex questions and obstetric concerns that those clinicians were more able to address. So what did we do? Well, we wanted to create a robust system, and in a hospital that has 8,000 deliveries a year approximately, there was a real need to formulate things so that anybody involved individually in the care of a pregnant woman with COVID would be able to follow a universal structure and not feel on their own or out of their depth or simply unfamiliar with what to do. Because whilst I show you the numbers are high in comparison to our first wave, actually that's still not a large number of women in comparison to what we see every day. And the key thing here is that we had a robust but short list of clinical responsibilities for whoever met the patient first. So thinking about a VTE risk assessment, arranging a growth scan, and making sure that our COVID team knew about the patient and ultimately could then double check that everything was being done properly. This is where the COVID Care at Home system comes in, because they're ready to go home, but they're still at risk of deterioration. And again, we then had a follow-up plan about repeat chest x-rays and things like that. But then you come on to the more complex issue of where you admit women with respiratory issues. So we've all had our previous scenario that I described to you in maternity. An occasional woman with pneumonia would be perfectly appropriate to have in our maternity setting, needing a bit of oxygen, and could have the medical team input as they needed. But we were concerned that we couldn't deliver that level of care to the level required if the number of women with COVID went up. So there were quite a number of discussions which came to the conclusion that in a woman with no obstetric concerns, they would be managed as if they were not pregnant, and we would provide rapid and appropriate obstetric support irrespective of location in the main hospital. If they had any obstetric concerns, we would do exactly the right medical and obstetric support, but it would all be coordinated in an obstetric setting as best we could. So then you're left with a scenario that is quite nerve-wracking for my medical colleagues, which is suddenly very pregnant women in a non-obstetric setting in a decent number. And this makes my physician colleagues understandably anxious, because there's not an absolute cutoff, but there is an understanding that the more pregnant a woman is, certainly in the third trimester, the more likely it is that she'll be managed in a maternity setting and will be physically located there, but with medical input. And obviously we were changing that quite dramatically. So I had an auto text that I would add to every electronic record, almost like a recipe of things that they needed to follow and think about. And we'll touch on some of these in more detail. But importantly, those were the approach to treatment in pregnancy, the ensuring that we were sticking to the guidelines that had all been agreed about VTE prophylaxis, but importantly thinking about other consequences of those treatments. For example, giving them steroids, but making sure that not only were we monitoring the blood glucose, but our physician colleagues were aware of our very tight targets in pregnancy, that they don't stick to quite so regimentedly in a non-pregnant setting. We also made a plan to give everyone on steroids a proton pump inhibitor. That became very useful when planning an emergency delivery, and there was less anaesthetic worry about the gastric protection and needing a PPI before that. It was also practical, so reassuring and reminding my physician colleagues about the data, about cross-sectional imaging, that actually even if they'd had one CTPA, we weren't worried about them having another if there was a clinical indication to do so, to make sure that our physician colleagues were able to give them that reassurance. But they also needed a plan for exactly what to anticipate for fetal monitoring and when fetal steroids would be given. And we have to say we adopted a very low threshold for giving fetal steroids early on in the admission, because as everyone is familiar, the trajectory of COVID infection is so unpredictable that you can't pick out those individuals who are going to really deteriorate and those who are going to stabilize. And so actually we wanted to get fetal steroids into anyone who ultimately might benefit from them quite early. A really key thing for us was maternity early warning scores. So in the UK particularly, there's a huge drive for the use of early warning scores as a predictor of decline and warning of a potential cardiac arrest in the non-pregnant setting as well as in maternity. But we don't have an electronic system that is able to easily embed a maternity early warning score for a pregnant woman in a non-obstetric location. So by definition, they entirely different early warning scores were automatically being used for these women because of their location. And so we had to make sure and proactively remind their clinicians that our thresholds for blood pressure monitoring and treatment intervention were different. We were also keen, obviously the recovery trial was coordinated in Oxford as one of the main centres, and so we were very keen to encourage pregnant women to be asked about treatment trials. And often we found that there wasn't hesitancy from the patient, but it wasn't actually as automatic as it might have been for other patients to be approached, and that a different team of, for example, research midwives were required rather than the research nurses based on the ward. So we wanted to prompt everyone to consider that and remind them of the importance of it. And the final things we touched on were the tendency to ketosis, which we know about in COVID and in non-pregnant individuals. There's something about COVID infection makes that a bit more likely, but also remind them that ketosis happens much more readily in pregnancy. And in contrast to a non-pregnant patient, where it's common to think of ketones, but almost invariably when the blood glucose is high, we wanted to make sure that clinicians were thinking about ketosis even if their blood glucose levels were reassuring, because we know that that is a separate entity and can be problematic for pregnancy. And then reminding them of the basics about positioning after 20 weeks. It sounds very obvious, but actually it was a helpful thing to put in, because I came across a couple of scenarios where they'd trialled a pregnant woman lying flat on their back to see if she'd be okay for transfer for 20 minutes, 25 minutes. And actually, to us, that was obvious, but to the clinicians, it was not so obvious that that was a bad idea. So I talked about treatment and I glossed over it, but I'm coming back to it now. So we were pleased with the data about dexamethasone, as so many people were, that came out quite early on from the recovery trial. And whilst there weren't a lot of pregnant women in that part to any great degree, we are so reassured about the use of steroids that it was helpful to know that that was a treatment option, because that was a very straightforward treatment to translate into use in pregnancy. Now, they recommended, and I agree with their recommendation, that an equivalent dose of prednisolone was preferred because of the great difference in placental transfer, because they are metabolized differently between the two groups of steroids, dexamethasone falling into one and prednisolone falling into the other. What we saw, exactly like in other pregnant and non-pregnant individuals, is the predictable side effects of hyperglycemia, hence the routine glucose monitoring, and the gastric irritation, hence the PPI and management of that. Then came remdesivir. So you'll all know there was an initial study that showed there might potentially be a little bit of benefit, but then other studies have shown cast doubt on those results. And indeed, the use in the UK varied hugely between hospitals about use in the non-pregnant population. So some hospitals didn't use it at all, some hospitals were keen to use it just in case it worked, and some fell in the middle where it was considered occasionally. And in pregnancy, we have no data for remdesivir being harmful, but we don't really have much data on it being certainly any good, but certainly confident about its safety. And initially, it was only used on a compassionate basis in pregnancy in the early part of the pandemic, and you had to apply through the website to do this. We did not use it universally in pregnancy, but in certain circumstances, such as women who were really unwell at 25, 26 weeks, it felt appropriate to use, to give them the maximum options for helping them get over this without the need for intubation, ventilation, and potential delivery of a very preterm baby. Tocilizumab came out a little bit later, again, data from the recovery trial, and it has been used in pregnancy for rheumatoid arthritis previously, and so it was very reasonable to extrapolate the advice that was given to use in non-pregnant individuals and use it in exactly the same way if the same criteria such as CRP, time duration of symptoms, that sort of thing was used. And that felt appropriate and a good extension of the data. That came in at the very end of the pattern of the second wave of patients we saw, so we've not had large numbers of women locally requiring that. So what about delivery? Well, I'd love to be able to answer the question, when is delivery indicated, with a straightforward answer. And I can't give you that, because actually the path of COVID infection is so variable and the trajectory unpredictable that if we had used a set threshold, for example, the amount of inspired oxygen someone was requiring, or a certain point in their illness, that would have been really incorrect for a number of our women who then went on to successfully recover from the condition and deliver much later in pregnancy. But we had a small number of women who did require delivery for very severe maternal respiratory compromise. And in that setting, we used a similar threshold to influenza, saying, look, if this woman is very pregnant, if they are needing intubation and ventilation, actually, we think that it is now appropriate to deliver the baby. The other thing that comes into consideration here is that if they are requiring intubation and ventilation, then we know in COVID that proning is really successful as a way of improving their ventilation perfusion matching. And actually, with a very gravid uterus, this would not only been uncomfortable, but very difficult to achieve. And you would therefore have had to compromise on the position that the patient was in when they were very pregnant. Now, I wouldn't say that any of these decisions were made for practical reasons, but it is appropriate to take that into consideration. And I've already described a little bit about the different locations of our services. But again, the theatres where, if an emergency delivery was going to be performed, is also on a different level to our respiratory HDU. So we had to think very carefully about the timing of delivery and when to do that, but also it wasn't the easiest practical thing to suddenly arrange. So what we did, we had one of the three women was the prompt for this checklist, because we found that a lot of people are involved in an emergency delivery, as you can imagine, and there are a lot of things that are suddenly required that are probably completely routine when you're performing an emergency cesarean section on a labour ward, but actually are not at all routine when you're moving a patient from a respiratory support, a respiratory high dependency unit setting to theatres immediately. And so we created a list. A lot of those things will be very obvious to you, but we found it very easy we found it really helpful to formulate a list that people could work through, so that you weren't expecting a clinician, an obstetric senior trainee, for example, in the middle of the night to suddenly be called to an unwell pregnant woman and expect to remember and process all of these things in what is actually a very stressful scenario. And what we had in the end was we had, in at least one of the settings, we had a consultant obstetrician who stayed with the patient whilst they were being prepared for transfer, and we had a consultant obstetrician at the other end in main theatres, all scrubbed and ready to go. But obviously in two different places that requires communication, so we needed a really seamless pathway to make sure that this was all safe and there weren't assumptions made by one team about what the other team were doing. So what about severity in pregnancy? Well, I mentioned earlier that we had quite small amounts of data from China in the first wave, but what we had was pretty reassuring. But later on in the second wave, you can see that that did not feel the same. And I don't know, there are lots of potential reasons why that was. Could it be that simply the lockdown restrictions that I described to you put in the first wave were not introduced in the second wave to the same degree in the UK? It certainly didn't feel like the same full lockdown that we had in the first wave. Or was it the new variant that was increasing, had a predisposition for worsening infection in pregnancy? Well, a lot, and data will continue to emerge on this, and we'll build up our knowledge. However, a really useful recent study published in the JAMA Pediatrics was a multinational study, and this actually looked at the time window in several countries from March to September. So it looked at data earlier on than just the second wave that I've talked about with concern, and showed that both mortality and morbidity was increased in association with COVID infection. And again, obviously, this will have an international variation because of the way that different services are delivered, but certainly it backs up our concern that perhaps we were a bit early to be, the data early was a little bit too reassuring, and actually we've swung round to really clearly seeing that the third trimester of pregnancy particularly is a risky time. So this is where we currently are in the UK, terrifyingly quick increase in cases recently, and we don't know when that peak is going to stop, and I don't know what that means for pregnant women. However, that concerns me, but this concerns me more. So this is data from June, and if you look at the age group for adults of reproductive age, particularly our women of childbearing age between 20 and 39, that case increase is simply really quite concerning. And that brings me on to vaccination, because I think we have a really dangerous combination of things now, which is a rapidly increasing number of cases in that age group, coupled with very much more totally different lockdown restrictions to where we were a year ago. But we also have the big problem of vaccine hesitancy in pregnancy. And I just have one slide on vaccinations to lead me to my last slides. And we all know that pregnant women weren't really included in those vaccine studies, but I think it was important compromise comparison to see the different responses in the UK and the US. So the US responded by saying, well, we take your lack of data, we know that, but we'll respond by saying that pregnant women can decide for themselves. In the UK, the line taken initially was that pregnant women should not have the vaccine. And whilst that sounds straightforward, I do feel that that was a potentially damaging initial line to take in the absence of data, because it implied harm. What then quickly happened was it changed to vaccine recommended for women with high-risk medical conditions or healthcare workers only. And this was the Pfizer or AstraZeneca, depending on what was available. That then relaxed further and said that pregnant women should have it whenever their age group category was offered it. And I anticipate that that will change further in the next few months. We then moved from a Pfizer or AstraZeneca to Pfizer being preferred in pregnancy. Now, again, that was not because of concern about AstraZeneca. It was purely because in the effect of the US data and effect of their policy. And in the US, they therefore had lots of pregnant women having mainly the Pfizer or Moderna vaccine. And therefore, we've now got upwards of 100,000 women reported who've had the vaccination in pregnancy with no signal of any adverse outcomes. And that is why Pfizer has been advised in the UK over AstraZeneca. It's not because of concerns of harm, but about preferential data being available about the safety of it. But we are seeing really concerning levels of vaccine hesitancy in currently pregnant women. Reassuringly, in the last few weeks, I've noticed that a lot more women in early pregnancy have had their vaccination before they've become pregnant. So I hope that this is not a long-lasting thing, but there certainly is an ongoing concern about it. The most common thing cited to me is, well, doctor, you can't tell me what's going to happen to my baby in 5 years' time if I have the vaccine in pregnancy now. And I hear that concern and I understand it. However, I can't tell the women equally what the effect of COVID infection in pregnancy is on their baby in 5 years' time. But what I can tell them is that risk of preterm delivery, and we know of the consequences of early delivery and the risks of prematurity for babies, which, whilst unlikely, given I've shown you those numbers, is still a possibility and can be required for COVID in pregnancy. So these are just a couple of slides to tell you a couple of other things we did. We were very aware that pregnant women make lots of different groups of medics anxious. So I did a single slide for a reminder of what to think about and how to do things differently when a pregnant woman turned up on the medical take. Even reminding them about different heparin doses, because that's a really common thing that people don't know about. But we also did the same thing for COVID for obstetricians, because actually those numbers may look severe compared to the first wave, but in a busy hospital when you have lots of clinicians, that's very few COVID patient positive pregnant women per individual clinician. So in conclusion, I think that individualised care plans are essential for women with COVID. There's no rules you can draw about exactly when delivery is required, but a team approach of people who have an overview of the condition and the patterns noticed locally was invaluable to us, and I think is a good approach in general. Again, a lot of what I've told you is centre specific. The practicalities at different centres are different, and the lessons we've learned can't directly be extrapolated to every other setting. But a thing that made a real difference here is that we had those conversations early, and we were supported by our medical specialty colleagues, so that there wasn't hesitancy in the middle of the night and a change in plan. Everyone knew what the plan was, and therefore we could all progress properly. So I'm going to stop there. I've referred to a number of UK-based resources here that are useful for a bit more information about the pattern of COVID in pregnancy, and I'm happy to take any other questions.
Thank you very much, Dr. Fries, for this comprehensive lecture. I know you answered a lot of things which about the COVID-19. We know when we started last April or May, when we started to see patients here in Jordan, or even reading about cases reported in different parts of the world, we were in a dilemma what to do. Shall we take all the precautions for all pregnant women? Shall we see pregnant women, or just keep them at home and take phone calls and remote care? Or if we open our clinics, what precautions we have to do? And if we get patients coming in labor, do we have to ask for PCR testing before they are admitted to the delivery ward or for elective procedures? So we were in dilemma. And I think now we have more than 13,000 or 14,000 articles published since the beginning of last year till now about COVID, and we are enlightened by different experiences from all around the world. And I am glad to hear your experience in Oxford and in UK. And you mentioned about the maternal mortalities, and mentioned about how to go into assessment, use MEWS, maternal early warning scoring. I think now we got enough experience with dealing with patients who are at risk and patients who are having the disease, how to tackle these patients in delivery wards or in the theaters if they need elective procedures. But most people are till now confused about the vaccination. Every day we are asked about by pregnant women or women who are planning to become pregnant, do I have to take the vaccine or wait? I think you answered this to some extent, that a pregnant woman should not take the vaccine according to British guidelines. But there is a point here. You mentioned high-risk women or people who are working in the health services. I know these people are very careful, and if you vaccinate them, fine. But a lot of working women who go for their companies, or school teachers, or women who are working in as secretaries in different jobs, they are exposed as well. That's why I am worried about pregnant women not working with the medical services. In case if they travel by bus or travel or walking in the street or going to the mall or the supermarket, why we not give them and just restrict the vaccination for people who are high risk or women who are working in the medical services? In my opinion, we should encourage vaccinating all women who are pregnant, because I don't know which one is going to catch the virus. What do you think about this?
I think I may have been unclear, and I apologise. The initial UK line was that pregnant women should not have it, but then the advice evolved through the different advice through my slides. So there's a current advice is that pregnant women should have it in line with their age groups, because the UK is taking it was gradually reducing the age offer. And now, because of the third wave, there are vaccine centres for anyone over 18, so anyone can have it. And the vaccine centres are now much more comfortable vaccinating pregnant women than they were a few months ago. And I think that given we now have quite a clear suggestion that the risks of COVID in pregnancy are greater than that of a non-pregnant woman of the same age, that there will be continued support and advice for all pregnant women to be having it. And my hope would be that in the next few months or years, we view it like the flu vaccine and we view it like the whooping cough vaccine. But I feel that unlike those vaccines, which were just introduced and nobody worried, we've started on such a back foot with this vaccine that it's going to take us quite a lot of time to catch up with that. I totally agree with you that we should be thinking about the risk for every pregnant woman, because ultimately, even those women who tell me that they stay at home and they're not exposed, actually a lot of them have children going to school, and they're going to have unscheduled hospital visits where they will meet staff and there will be other patients there. So their risk is not possible to completely mitigate and just lock them away.
Thank you. The other thing is, when is there a sharp cut point of to say this woman is going to be intubated or in respirator and should be delivered regardless of the age of a pregnancy? Because we've been asked this question many times. 26 weeks, 27 weeks, the physicians want to put her on respirator. Shall we take the baby out or keep the baby and see what is going?
The really difficult one that I've noticed from talking to my obstetric colleagues in different centres in the UK is that, in contrast to some other respiratory conditions where their woman is compromised, but then on delivery of the baby, they sit and watch the woman get better. COVID doesn't do that to the same degree. And that makes some form of sense, because if their lungs are full of COVID, then actually you haven't got rid of that. You've just got rid of the diaphragmatic splinting. And so I think we have to be really clear why we are delivering them. And I don't think pregnancy and delivery alters the course of the illness to a great degree. But I think that when they are very pregnant, actually you are restricting the potential positions they can be in and the proning. And actually when they're very pregnant, it's difficult to provide that, close obstetric monitoring when they're intubated and ventilated. So at that point in the 3rd trimester, we thought about delivery. I've certainly know of complex women who were early in the week's 20s, 20 to 25, who were not delivered, who were intubated and ventilated, and some of them were put on ECMO while still pregnant. And I think that is the really difficult time. I think before 20 weeks, it's quite difficult to justify delivery. I don't think it particularly alters the course of the illness, and I don't think it compromises their care. So I think in that setting, it would be quite difficult to justify a pregnancy intervention. And I think one should probably concentrate on their management exactly as if they were not pregnant at that point.
Thank you. Dr. Friese, we have a few questions. Sorry. Naam?
There are a few questions on the
Yes,
Q&A.
I want to, Dr. Friese, there are some questions from our attendees. Dr. Bushra Mihi, would you, she put a question for Dr. Friese, would you recommend prone position in the 1st and 2nd trimester?
So again, I think it depends on the woman. So there are some women who are obviously easily pronable up to 20 weeks or so. There are some other women who aren't, and it's going to be much more uncomfortable for them. But there are compromises. So there are semi-prone positions, being on a lateral side, that certainly our physiotherapists did with some of our very pregnant women. So I think it should be considered in anyone where you might consider it if they were not pregnant, but appreciating that might be physical restrictions that make it unbearable.
Yeah, there's another question from Sadula. Pregnant ladies who are post-COVID asymptomatic with high D-dimer, do they need vascular thromboembolic prophylaxis?
So we would not advocate routine high D-dimer monitoring, but we followed national guidelines which suggested that anybody who'd had COVID infection should have prophylaxis for at least 10 days after that infection. And in some women who were still immobile and unwell with it, it was appropriate to carry on for longer than 10 days until that infection was over. But I wouldn't advocate using the D-dimer as a determinant of whether that was needed.
The last question, I think, from Dr. Safarini, concerning COVID-19 vaccination. Is there a preferred gestational age for the pregnant lady to receive the first dose? And what happens to the ladies who received one dose of AstraZeneca and got pregnant after that?
So there is no official guidance to suggest that the first trimester is any riskier to have the vaccine than later on. And part of me feels that you want your woman to be optimally protected by the third trimester, ideally having 2 doses by that point. But in lots of cases, actually, people's anxiety will lead them to have a vaccine after 12 weeks. And I don't think that's an unreasonable approach, but I don't think there's any justification for delaying it after that. And I don't have any medical proof for saying they have to wait until after 12 weeks. The AstraZeneca one is an interesting one. So, and a commonly asked question, our current policy is if they've had 1 dose of AstraZeneca, then it is okay for them to have another. We don't think the risks of that are particularly high in pregnancy, but there is data emerging about the use of the heterophilic prime booster. So 1 vaccine of 1 type followed by a different type. So I suspect in the months to come, we will find that people are a bit more relaxed about the mixing the type of vaccine, but at present we're not doing that. And I think that it's not unreasonable for someone to have the second dose.
I think because of the time, I would like to thank you, Dr. Fries, for a very important lecture. And thank you for your efforts. And we hope to see you in the future in Jordan.
Thank you
again. And I apologize for other people who ask for questions because of the time. We can't answer all of these. May I leave to Dr. Abir Annab to present the next speaker. Dr. Abir, please.
Thank you very much, Dr. Mazen. Dr. Joanna, are you with us? Yes. Hi, Joanna.
Hello, good evening.
Nice to see you. Sorry to interrupt your vacation.
Not at all. It's a pleasure.
I'm honored to present our next speaker, Dr. Joanna Mother from UK. She's a consultant obstetrician and gynecologist at the University College of London Hospital. She is a lead obstetrician for the UCLH Diabetes Maternity Service and audit lead for the Women's Health Division. She's a clinical director for the National Confidential Inquiry for the Maternal and Child Health, where she's currently leading a UK research project about obesity and pregnancy. She's currently involved in collaboration between CIMIC and UCLH research project for diabetes and pregnancy. Her lecture for today will be about diabetes and pregnancy. And we apologize again, Dr. Joanna, we had to steal you from your vacation. And we're so pleased that you could join our webinar today. And we're looking forward to hear your lecture. Please, Dr. Joanna.
Thank you so much. I'm very honored to be invited. I look forward to sharing my thoughts with you. I'm just going to try and share the screen, yeah, if that's okay.
That would be great.
Bear with me. Thank you. Can I just confirm you can see my slides?
Yes, very clear. Go ahead.
Okay, lovely. Fine. So I just want to share some of my thoughts about diabetes in pregnancy. I've been in this field since I was appointed as a consultant. And thank you for the kind introduction. Just to say that I am no longer working on the national projects of obesity pregnancy. That was a little while ago, and they've completed. But yes, I was involved in that. So this is what I want my talk to be about today. And you can see this. I want to just briefly go through the general things first, the types of diabetes, the risks, the treatment, some of the psychosocial issues which are so important. And then I'm just going to go into the things that as I get older, I realize we don't really understand. Yeah. So the 3 dilemmas, the screening, the diagnosing, and the preconception care. And I just want to just go through those a little bit. And I'm going to do my best to stay within 30 minutes, and please tell me if I'm running out of time. So this now everybody will know, but it's just to really give people a little bit of a refresher. So we know that type 1 diabetes is when the insulin-producing cells in the pancreas, they have been destroyed, so they cannot produce insulin anymore. And these women will definitely need insulin, because if they do not have insulin, they will die. In type 2 diabetes, which is becoming so much more common in all areas of the world, and it really is a huge public health problem. The body can still produce some insulin, but not enough. And also, a person's body is resistant to insulin. And we know that it is more common in people with high BMI, with obesity, and also certain ethnic groups, such as Black and Asian, which is a particular issue in the UK. And we know that it tends to run in families. Gestational diabetes is obviously the biggest group we will see in pregnancy. And this is any impaired glucose metabolism that we diagnose during pregnancy. And this is one of our dilemmas, how to diagnose it. But again, all maternity services all over the world will have a huge population of gestational diabetes usually. And the last one is very rare, but we put it in for correctness. And this is called MODY. It's maturity onset diabetes of the young. It's an autosomal dominant inheritance. It's caused by mutation of one gene. So if a parent has it, then the offspring have a 50% chance. And usually they come very young. They are diagnosed very young. These are rare, however. So, I mean, I'm sure I don't even have to talk about the risks of diabetes in pregnancy to this group. I'm guessing everybody probably will in fact know more than I do. But you can see from some of the pictures what the risks might be. So we know about the big baby. We know about the high cesarean section rate. We know about stillbirth. We know about shoulder dystocia. These are kind of the big headline issues that make people very worried as obstetricians. It's funny, when I talk to my trainees these days, and I say, do you know who Pedersen was? And they say, no, we have no idea who Pedersen was. Actually, Jorgen Pedersen hypothesized a very long time ago, in 1952, the pathway as to why a woman with diabetes has got the problems that then lead the baby having various complications. And he was completely right. And so what he knew or hypothesized, which was then proved to be right, was that if a woman has got high blood glucose levels, this goes across the placenta by pure osmosis to a maximum level of about 13 to 14 millimoles per liter. And so the baby is now bathing in this glucose soup. So the baby is now surrounded by high blood glucose. And therefore the baby has to produce more insulin to deal with this glucose. And so the baby becomes hyperinsulinemic, has a high level of insulin. And actually, it is the high level of insulin that causes many of the problems in the baby. For instance, insulin is a growth hormone, and so it will increase cell growth, and the baby becomes big with a big liver. That's why they have a high abdominal circumference, and they become generally macrosomic with the chubby chin. And this is why they have a higher risk of shoulder dystocia also. There's a lot of fat distribution here and the chubby cheeks. And then we know that insulin increases red blood cell formation. And so the baby is born very polycythemic with a lot of red blood cells. And then when those red blood cells break down, the baby's liver is too immature to deal with it. And so they become jaundice. So there's a high chance of jaundice in a baby whose mother had high blood sugars just before birth. We also know that insulin interferes with surfactant, and so the babies have got a higher chance of having respiratory distress syndrome, especially if they are born by planned cesarean section. We know that when the baby is born, now suddenly it is away from its mother, which had all the high blood sugars, and so the baby has a high insulin, but suddenly no glucose, and so it will have neonatal hypoglycemia, where the blood sugar falls. The baby can become very unwell and can have seizures and need neonatal admission. So this is Pedersen's theory, which explains so beautifully exactly all the problems with the baby. Again, I'm not going to go through this, but you can just read for yourself, the different risks that we think about for the mother and the different risks for the baby. And at the bottom, I think I've got actually the risk for the baby, in its life after it's been born, which is the metabolic syndrome, where there's an increased risk of obesity, overweight, diabetes, cardiovascular disease. So even when the baby's born, it takes this risk with it into its childhood and adult life. So it's an important problem, and it's a big problem. Now, this is just data from the National Diabetes in Pregnancy Audit in the UK, and this is an audit that receives data from all the acute hospital trusts in England and Wales. And it has an overview from NHS England is the one that commissions this, and it's carried out by our NHS Digital, which collects data on the whole population. And basically, this data shows the level of the problem. So you can see that the stillbirth rate in type 1 and type 2 diabetes for 2018 was 13.7 per 1,000 total births, compared to 4.2 in the general maternity population. And also the neonatal death rate, you can see, is also much higher, 10.4 per 1,000 live births compared to 2.8. So this is a problem that hasn't gone away. Before I became a consultant in 2003, I was doing a lot of research in diabetes in pregnancy, and it was always, how can we change the story? How are we going to improve these terrible stillbirth rates? How can we make the pregnancy safer? And now I'm 17 years a consultant, and I can see that we actually haven't changed very much. So it's an ongoing problem. The new thing for England and Wales is that actually type 2 diabetes is now showing a higher stillbirth rate than women with type 1 diabetes. Before it was about the same, but now actually type 2 diabetes has a higher stillbirth risk, which is a huge problem, because this is actually the much greater numbers in terms of the women you see in pregnancy. So moving on from epidemiology and statistics and coming to clinical treatment, what do we do for women with gestational diabetes and also type 1 and type 2? So we know that diet in pregnancy is absolutely essential. It is our first line treatment. And the one thing I do see, which might be different in the Jordan, is that certainly doctors particularly are perhaps not always as proactive as they could be to engage with women to ask about the diet and find out exactly what their lifestyle is like, because it could be that you could just make some big differences with some small changes. So we know the diet should be low GI carbs and high protein and high fat. Obviously, high fat forever would not be healthy, but high fat in pregnancy is very important because it will decrease the absorption of glucose and delay the absorption of glucose into the bloodstream from the gut. So it is really important to have high fat if you're going to have carbs. Exercise, we don't think about it enough. Certainly in my hospital and in my service, we do talk a lot about exercise to the women. We say, as soon as you eat, you get up and you walk for 20 minutes. Half an hour would be even better, but at least 20 minutes. If it's bad weather, because we know in England the weather's usually bad, you walk in your house. And this really will bring down your blood glucose levels so quickly after you've had your carb load. Metformin is the only oral medication that is approved by our national guidelines, the NICE guidelines, because there is not much information about other medications in pregnancy. Metformin is very safe. It has been well documented by a multi-center study in 2008. It's safe in pregnancy and also safe when they followed up the children to 8 years old. It improves the sensitivity of to insulin and also decreases glucose production by the liver and absorption from the intestine. So we use metformin as first-line treatment in women with diabetes, gestational diabetes. In pregnancy, you need to have short-acting insulin, and so we use short-acting insulin before each carbohydrate-containing meal. Generally, in England, we use Novorapid, which is insulin aspart. And you can see here from the slide that it starts to act in about 10 to 20 minutes. So you need to take it not just before you eat, take it about 20 minutes before you eat, so it starts to work. And then it is a very short-lived medication, and It'll go up in about an hour or two, and then the effect goes down. So it's very suited to meals. And then we give a long-acting or intermediate-acting at night, which is for your basal glucose, which will help with your fasting glucose the next morning. We know that glucose generally goes up in early morning as a result of increased cortisol in all human beings, but obviously in diabetes it's exaggerated. So the Humulin I will last long enough through the night, early morning, and through the rest of the day to just keep your fasting levels down. Psychosocial issues. As I've got older, I have realized that actually this is something we don't think enough about. Women who are diagnosed with gestational diabetes, this is a healthy woman quite often, or she might have had some other comorbidities, yes, like hypertension, but she didn't know she was going to get diabetes. And then suddenly her expectation for that pregnancy has changed. Suddenly she's got something that people are telling her there's a risk of stillbirth. This could happen to your baby. Your baby could be really big. It could get stuck. The labor could be very difficult. And so they are frightened. I see women who are very frightened. And I also see women who are very angry with me because I have told them they have diabetes in pregnancy. And their first emotion is to express their anger. And then because they are frightened, they want to have as much control as they have. And so the woman will say to me, I don't want to be induced. I don't want my labor to be started because I'm losing control. So I will have a cesarean section because this way I can gain my control. And I see a lot of this, that we have to work. And as doctors, as obstetricians, this is not our expertise. And I believe that all services who look after women with diabetes, we need to have a psychologist working with us. Because as clinical obstetricians, this is really not, we don't have the time or the expertise to be able to help these women. I've written down here social and cultural norms. I have seen so many women with type 2 diabetes who don't want to tell their families that they have diabetes because in some cultures it's a stigma, and in some cultures the partner may leave them, and therefore they want to keep it quiet, or they believe that type 2 diabetes is a more gentle diabetes than type 1 diabetes, so they don't take it so seriously. Also in England, or in the UK, we have a big problem with pregnancy planning. Women don't plan their pregnancy. And so if you're telling a woman with type 1 and type 2 diabetes to be careful to plan their pregnancy, it's not going to work because women in general don't plan their pregnancies very well. We know it's less than 40% in the UK. Lifestyle changes. A woman maybe has not a very good lifestyle. She doesn't exercise very much. She is not eating the right food. Suddenly she has diabetes in pregnancy, and we say to her, you have to eat very little, low GI carbs. You have to exercise all the time. And this is difficult for women. The last one is the expert patient, the woman with type 1 diabetes who knows more about her condition than the doctors do because she has been living with it for many years. And sometimes we feel intimidated, and therefore we don't always help this woman in the right way. For instance, we have had, sadly, a maternal death over the years in different hospitals here and there in the UK, because the patient with type 1 diabetes says she knows exactly how to manage her diabetes, doesn't want the staff to be involved. She's in a side room. She goes in there, and overnight she's there by herself. And in the morning, they find that actually the woman has died from a hypoglycemia. We need to be more ready to challenge women and to explain to them that we are there to help them as well. Coming on to my dilemmas, screening for gestational diabetes is the first dilemma. How do we actually tell that a woman has it? So, first of all, if you're going to use a screening test, it's got to be sensitive. It's got to pick up the maximum percentage of women who have diabetes, because we don't want it to pick up only a few. It's got to be specific. We don't want to pick up too many women who don't have diabetes. It's got to be acceptable, or women will not do the test. And it's got to be robust. The whole process has got to be robust. So I must say, I don't know how, different countries and in the Jordan screen for diabetes. In England and in the UK, the general national guideline is to use risk factors to screen. But if you look at this table, you will actually see that risk factors are not a very good screening method because the sensitivity is only 50%. That means you will only pick up 50% of women with gestational diabetes, and you will miss half of them. And the others you can see, glycosuria, glucose in the urine is not very sensitive. It will not pick up many women. A random blood glucose will not pick up any women. So if you want to pick up the maximum number of women with diabetes in your population, it should really be fasting blood glucose or a 50-gram glucose challenge test. The problem with risk factor screening, in addition to low sensitivity, is that there's a human error which can occur, because certainly in the way it works in England is the woman comes pregnant, she sees a midwife, and then the midwife, who is a human being, has the responsibility for identifying if this woman has risk factors, and then she needs glucose tolerance test later in the pregnancy. But that midwife might miss it, or the woman may not tell the midwife. And so then you've lost your chance to find out. And we had our national report in 2015, which looked at babies who had died in pregnancy. And they found that half of them had at least one risk factor for gestational diabetes, that's the mothers. But of those mothers who had one risk factor for diabetes, only about a third of them had been offered a test, a glucose tolerance test in pregnancy. And so my personal opinion is that risk factor screening is not the best way to diagnose or to screen for gestational diabetes. In my hospital, we do use the 50-gram glucose challenge test. The second dilemma is how to diagnose. This has been a problem over the years, over the world, different countries, different hospitals, all doing different things. So really, it's what's the evidence? And you've also got to think, when you use your criteria, how many women will you find? Because there is no point picking up half of your population if you don't have enough staff to look after them. So you have to be a little bit pragmatic about that. WHO 1999, we don't use that anymore, but that was the old criteria, and they based those numbers on the risk of future diabetes. Then we had the American 2000, and again, they looked at pregnant women, and they again based their criteria on the risk of that woman getting diabetes in later life. Then we have the one that most people know about, the IAD-PSG, the International Association of Diabetes, the pregnancy, I always forget that, the Pregnancy Study Group. They based their criteria on the very good long-standing observational study, HARPO. And they based their criteria on what would happen to the baby. So the baby becoming bigger, having more body fat, and having more cord C peptide, which is a derivative of insulin. So evidence the baby was having to produce more insulin. And then we have the UK, England, NICE guideline criteria, which is what is used nowadays in England in most hospitals. And that is a health economics model. So we had the group thinking about, they had 13 different possible criteria suggested by an expert group, and then they worked out which one was most cost effective. So these are the different criteria. Now, the problem is, well, we know now that the WHO 1999 is no longer in use. You can see my cursor, I hope. So this has gone. The ADA stopped this set of criteria and has moved to IAD-PSG. WHO has also adopted IAD-PSG. So IAD-PSG is adopted by most of the sort of high-level global organizations. And you can see it's got 3 values in it: 5.1 fasting, 10 1 hour, and 8.5 at 2 hours. And this is after a 75-gram glucose load, and only 1 value needed for you to have diabetes in pregnancy. And you can see how different the England criteria are, where we use 2 values, fasting and 2 hour, of 5.6 and 7.8. So such a big difference. Of course, you will pick up different women and different numbers of women, depending on which criteria you use. IAD-PSG will pick up a lot more women than NICE. And so it will be more expensive if you use IAD-PSG for your organization, because you will have more women to look after. At UCLH, you can see, which is my hospital, we have very nicely combined the two, because we are trying not to lose the IDPSG. So we do use the NICE, which is the 5.6 and the 7.8, but we also do a little bit of IDPSG. We have a 1R value as well. Dilemma 3, preconception care. How do we actually achieve an effective strategy for preconception care? Do my audience have a tested set of interventions embedded into your healthcare system that the health professionals are trained to implement, which are regularly audited? And when we are thinking about preconception care, do we think about social issues, cultural differences amongst the different groups of women? Well, certainly in the UK, we do not have a set of interventions embedded into the healthcare system. We don't really have good training, and it's not audited. So we don't really have this system in place in England. And we are not very good at considering social and cultural differences in terms of how do we actually reach these different women, and actually explain to them what preconception care is about. So this was the National Pregnancy and Diabetes Audit question, which looks at were women with diabetes adequately prepared for pregnancy? So this is the national audit question for England. And they say, well, is the woman using 5 milligrams a day until 12 weeks? So they should all be doing that. Do they come into pregnancy with their HbA1c less than 6.5% or 48 millimoles per mole, which is what we consider to be reasonably good control? Are we using metformin, but stopping all other glucose-lowering medications? And are we stopping medications that could be dangerous for the baby as it's developing? So this is the national audit question for England. Now, if you look at this, which is the percentage of pregnancies where 5 milligrams of folic acid was taken before pregnancy, and it's looking at the years between 2014 to 2018. The grey bar is type 2 diabetes, and the blue bar is type 1. You can see that absolutely nothing has changed. So in 2014, just over 20% of women were taking 5 milligrams of folic acid before they were pregnant. And in 2018, it's the same percentage. So we have not improved anything, even though we are very good at documenting the stats. And it's the same for type 1. And then if you look at the percentage of pregnancies, this is the same national audit, you look at the percentage of pregnancies where your glucose control, your first trimester HbA1c is less than 48 millimoles per mole, which is 6.5%. And you look from 2014 here to 2018, there is no difference. Only less than 20% of women with type 1 diabetes have an HbA1c less than 48 millimoles per liter. Type 2 diabetes less than 40%. Nothing has changed. It's like a straight line. So again, we can see that whatever we're doing, it isn't working. It's not changing anything. These are some of the issues I see in my clinic. Women are not on folic acid. They're not testing their sugars. They have extremely poor glycemic control. They weren't on contraception before pregnancy, or they were actually given they were actually helped and were pregnant because of assisted conception, despite having poor diabetes control. So in conclusion, this is my last slide, and we have a high risk of adverse outcomes in this group of women. We know that preconception care is important, but we don't have a mechanism to achieve it, and we can see that nothing is changing. Our current screening protocols and our diagnostic criteria, certainly in England, are missing many women with gestational diabetes. And when the woman becomes pregnant, there's a very narrow time, a very narrow window of opportunity for the obstetricians, for the diabetologists to get this woman, try and improve her glucose control, try and work on the psychosocial issues, and try and talk to her about how to improve her lifestyle after pregnancy. And this is difficult because we only have, well, less than 8 months, because a lot of them will be, delivered a little bit preterm. these are my thoughts, and I'm very happy to have been able to tell you them, and I would also be happy to take any questions.
Thank you very much, Dr. Joanna, for this very nice and thorough presentation. There were two questions, actually. One of them from Dr. Smita, and she was asking about the HbA1c level before we allow them to get pregnant, and I think you have answered it. Maybe the best thing is to go below 6.5%.
Yes, the answer is less than 6.5%. And my experience is that if you tell a woman, again, it's a different cultural situation, but here you have to expect that the woman will, in England, you have to expect that the woman will get pregnant even though you tell her it's not safe. So quite often this will happen. And it's really important, I think, to tell them well before they were even thinking about pregnancy. I think it's when they were diagnosed with diabetes to say that pregnancy is a dangerous time. And if you want your baby to be safe and yourself to be safe, you need to really be thinking about this well in advance.
There's another question from Dr. Wafa Mohsen. She's asking about white classification for diabetes. Do you think we have to reconsider the diagnostic tests for diabetes?
Yes, yeah. So the white classifications, I can't remember because I haven't looked at them for a long time, so I won't talk about White's classification. But in terms of reconsidering the diagnostic test, I think it's all about what we're trying to achieve. Because if we're trying to achieve more safety for more women, we have to realize it's going to become very expensive. So it is really very much about funding and the cost to the health system. Yes, we can make it safer. Yes, we can avoid more stillbirths or more macrosomic babies, but we would have to consider the cost, basically, and that's something that everybody struggles with.
Okay, there's a question about now we have more women going with bariatric surgeries. What do you think is the best way to measure their blood sugar, especially that you can do the oral GTT for them? Do you go for blood sugar readings, and how do you do the blood sugar readings later on? You just keep on following the fasting postprandial measurements? What do you think?
Yes. So thank you for the question. So in terms of women with bariatric surgery, yes, we definitely don't do a glucose tolerance test for them because they can't tolerate quite often a big glucose load, and they will have what they call dumping syndrome, where they become very ill, vomiting, dehydration. And so for these women, we actually do 1 week of home blood glucose monitoring, where they have their own meter, they test their blood glucose fasting and 1 hour after the meal. And then we have particular criteria in our hospital. If it's 5.3 or more of fasting or 7.5 or more of 1 hour post-meal, if we have 2 results in 1 week that are above the target, then we say to them, yes, there is evidence you have diabetes in pregnancy. So we are quite strict with our criteria, but that is most other hospitals in London follow this as well. And so, yes, we would do home blood glucose monitoring. And then when we diagnose them, if we do, then yes, we would carry on with that testing system throughout the rest of the pregnancy.
And there's another question asking, would you allow pregnancy to go on beyond 40 weeks for well-controlled diabetic ladies on oral hypoglycemic agents like, metformin?
I love the question. Thank you very much. So the NICE guideline says that if there is no complication, or it's very, if they say it's not complicated diabetes, then you can go to 40 weeks and 6 days of pregnancy. And the way our hospital has interpreted this guidance, and I think other hospitals as well, is that if the woman is requiring any medication to control her blood sugars, then we say, actually, we are not going to go beyond 40 weeks. So we will stop at 40+0 if they're on any medication. If they're on diet only with absolutely perfect sugars, for me, all the sugars have to be absolutely good, then I will allow them to, when I say allow, recommend them to go to 40 weeks and 6 days. But any woman on any medication, we would say less than 40 weeks, and exactly how much before depends very much on the sugars, and also I do look at the size of the baby. I don't want the baby to be more than 4 kilograms if possible, because there is some evidence from previous national work in England that above 4 kilograms, the risk of shoulder dystocia actually jumps up quite high.
What do you think is the best way to do the fetal well-being tests? Do you go by the biophysical profiles, third trimester? Do you go by non-stress test? What do you think is the best way to secure or decrease the stillbirth and immune the baby from complications?
Thank you. So again, a very good question, because nobody really knows. So I appreciate that question a lot. It's what we all struggle with. So certainly there is no evidence that biophysical profile or Dopplers or scans are useful for predicting the risk of stillbirth. So these are not useful tools. What I am very, focused on, and I think most units are, is the mother's perception of fetal movement. So if the mother says to me, I think my baby is moving less, or in some way it has changed and I'm a little bit worried, I take this very, very seriously. They have diabetes in pregnancy. And if they are term, 37 weeks or more, I would actually recommend delivery immediately. So I take that very seriously, because I know we don't have a good test, like the biophysical profile that will be a predictor.
There's a question from Dr. Ibrahim Mashini. Why do you think you need to use the folic acid 5 milligram dose other than the 0.5 or 0.4 milligram? Why do you think we have to go with a higher dose?
Okay, thank you. So, the reason for that is the Cochrane review looking at high dose, looking at women who have higher risk of neural tube defect, actually showed that in this group of women, 4 milligrams and more was significantly useful in decreasing the risk of recurrence of neural tube defect. They did not look at women who were pregnant, but who were diabetic rather. But it was looking at women at higher risk of neural tube defect. And we know that women with diabetes have got a much higher risk of neural tube defect than the general maternity population. So because they are in that group of women with a higher risk of neural tube defect, we have very good systematic review evidence that shows 4 milligrams and above is preventive for recurrence. We use 5 milligrams in the UK because that is what is available, but some countries will have 4 milligrams actually. And so it is so important to have the higher dose rather than the standard 0.4.
Yeah, and the last question will be, when would you go for a cesarean for a diabetic lady? And would you induce if you think that the baby is 4 kilos at 39 weeks?
Oh, these questions are very challenging,
I know.
but I like them. Thank you very much. It's such a good question. So would I induce, at what, I think the question was, at what gestation would I induce? Or when would I do a cesarean?
If the baby, I know weight measurement is not very accurate, especially with third trimester and pregnancy, but with diabetes. But if she's, it's a 4 kilogram baby, would you induce her just because she's a 4 kilogram baby?
So it's interesting. No, absolutely. So if I have a woman and we've done a scan and I am assuming, the baby could be putting on 200 grams a day, I basically have a very frank conversation with her. I say, look, this scan could be up to 15% of error. So I say, this scan, actually, your baby could be weighing anything between this number of grams and, the second number of grams. It could be this type of range. So we know that your baby could be more than 4 kilograms weight at birth, but actually it could be much less. So we have to decide if we are going to deliver you earlier to try and minimize the risk of shoulder dystocia, and we have to recognize that we may be wrong and your baby might actually be much smaller. And so I have this conversation with them, and they also have to decide with me what they want to do, and I get different answers from different women. In terms of cesarean, I would be thinking or talking to the woman about the need for a cesarean from 4.3 kilograms onwards, because I know from the National Confidential Inquiry data that when the baby was birthed, and this was all the women in England, the whole of UK actually, when the baby was 4.25 kilograms and above, the risk of shoulder dystocia jumped 25%. And so I am uncomfortable to take that risk. And I explained to them that this was observational data. It is not randomized controlled trial data. We'll never have an RCT for this. And I say to them, this is something we need to think about. I don't say they have to have it, but we have that conversation if the baby is 4.3 or more. But ultimately, I tell the woman everything I know, the fact that we could be wrong, and then we make the decision together.
Yeah, thank you very much. I think we have to stop here. Thank you very much, Joanna. I'm pleased to meet you online on Zoom, and looking forward to see you in person. And I wish you a happy vacation. Please go and enjoy it. And thank you for sharing your knowledge with us. Thank you very much.
Thank you. It's a pleasure. Thank you so much.
I'm going to now move the microphone to Dr. Mazen Zibde to introduce our last speaker, Dr. Fadi. Please, Dr. Mazen.
Thank you, Dr. Abir. Thank you, Fiona. Our next speaker, Dr. Fadi Mirza. Fadi Mirza is known to most of us here in Jordan, and we know him for many, many years. He is a diplomat, American Board of Obstetrics and Gynecology. He is board certified as an obstetrician and gynecologist, and board certified in maternal and fetal medicine. He's associate professor of OBGYN and director of obstetrics and gynecology residency program, and the director of clinical practice improvement program. He's the chairperson of the Credentialing and Privileging Committee at the American University in Beirut. He's adjunct associate professor in obstetrics and gynecology at Columbia University College of Physicians and Surgeons in New York. Dr. Fadi has a lot of publications, and he spoke everywhere in the Middle East about miscarriages, whether recurrent and threatened miscarriage. And we're going to hear from him what is new now in the year 2020 about threatened and recurrent miscarriage. Please, Dr. Fadi.
Thank you, Dr. Mazen. Thank you, everyone. It's great to meet friends after all those years, and I truly look forward to meeting everyone in person somewhere, sometime. So it's getting late, so we're going to jump into the topic, a topic that I believe you all agree with me is always of interest. It represents one of our bread and butter topics. It has certainly triggered a lot of controversy in previous years. And indeed, there has been a lot of action in the past few months or years, which has prompted this talk. So as you're going to see, my talk is going to be split into two sections, one that deals with threatened miscarriage and the other one that deals with recurrent pregnancy loss. Starting with threatened miscarriage, as you all know, refers to vaginal bleeding through a closed cervix during the first half of pregnancy. And threatened abortion is of interest to us because it really complicates up to 20% of clinically recognized pregnancies. And although the exact etiology remains unknown in most cases, this condition has been attributed to marginal separation of the placenta. And the term threatened has been coined because pregnancy loss does not always follow even after repeated episodes of bleeding or significant amounts of bleeding. This is a very important schematic, in my opinion, because it really shows the interplay between the risk of miscarriage and the weeks of gestation. So as you see, it's more of an early pregnancy issue rather than a second or third trimester issue. You see the significant drop in the rate of miscarriage as the pregnancy advances. What are the implications of threatened abortion or threatened miscarriage? Why do we really care about that topic that much? Well, pregnancy does progress to a miscarriage in approximately 1/2 of those cases. And the psychological burden on the prospective mother coping with this fear of an impending pregnancy loss cannot be overemphasized. And it's no surprise that threatened abortion has been associated in the literature with things such as depression, sleep disorders, anger, and marital disturbances. This is a real-life case, I think, that we see on a daily basis. A young, healthy, nulliparous female coming in after being married for about a year with her first pregnancy. Her last menstrual period was about 7 weeks, and she's seen in clinic where an intrauterine pregnancy is identified on ultrasound. The crown plank seems good, and positive cardiac activity is identified. So the patient's happy. She's probably accompanied by her mom, her mother-in-law, maybe not, her husband. Now with COVID, it's only her, but in our culture at least, there's major joy and happiness that comes with groups. So that patient is going to be happy, everyone around her is going to be happy, and then that happiness is short-lived because just 3 days later she comes to the ER, again accompanied by everyone with bleeding. The good news is that her cervix remains closed and positive cardiac activity is again identified, but everyone is staring at you and asking, doctor, what are you going to do to try to save this pregnancy? Because bleeding is scary, particularly to a nulliparous female who just, got the best news of her life 3 days earlier. Well, we're going to be asked about bed rest, something that we overuse and abuse in obstetrics. And I think you all agree with me that this is something that we use in just so many conditions: short cervix, twins, preterm labor, preterm contractions, placenta previa. I mean, you name it, it's just thrown everywhere. HCG injections, vaginal progesterone, oral dydrogesterone, and of course the option of doing nothing after counseling that patient. At least in our culture, that option E remains a challenge with many patients and their families asking for quote unquote something. We're going to start with option A, which is bed rest. The Cochrane has neatly looked at the studies. There weren't a lot of studies on that topic, but the conclusion was not in favor. There is insufficient evidence of high quality to recommend bed rest in the setting of threatened abortion. The same fate awaited HCG, although there were a significant number, or a higher number of studies in that setting. But again, you see that the conclusion of the Cochrane was not in favor of that intervention. That leaves us with progestogens, namely vaginal progesterone and oral dydrogesterone. Progestogens refers to a group of hormones that bind to progesterone receptors. They include natural progesterone as well as a number of synthetic forms. And we all know that progesterone secreted by the corpus luteum is essential for reproduction and maintenance of pregnancy as it prepares the endometrium for implantation of the embryo. And this was the reason behind prompting a lot of clinicians, researchers, patients to kind of explore supplementation as the answer to threatened abortion. This is another important picture that show, or graph or curves that shows the interplay between the sources of progesterone being from the corpus luteum in early pregnancy, and then the placenta takes over as we emerge from the first trimester. And this is important clinically as we decide on the duration of treating those patients if we're going to elect to pursue progestogens. Routes of progestogen supplementation, we're all familiar with those: oral, vaginal/rectal, and intramuscular, and the various forms that we also use in obstetrics, namely progesterone, dydrogesterone, and 17-hydroxyprogesterone. So we're going to conduct the same exercise that we just did for bed rest and HCG, which is the Cochrane review, and see what does it say about the use of progestogens. Well, the initial Cochrane by Wahhabi et al. Included 4 trials that were deemed to be of adequate design to be included. Total of 421 participants. One of those studies was by our colleague Dr. Mazen. The other one was by Pandian. Those utilized oral dydrogesterone. And there were 2 studies that included vaginal progesterone, one by Gerhard and the other one by Palagiano. The overall results were as follows. There was actually a statistically significant reduction in miscarriage rate with the use of progestogens, as you see, nearly 50% reduction. Then the authors conducted a sub-analysis of the oral versus the vaginal route, and with the oral studies, namely 2, the statistical significance was indeed significant, as you see here, with an effect size of 0.54, but that was not the case for the vaginal progesterone sub-analyses, where you see the confidence interval crossed 1, demonstrating no statistical significance. Of course, I'm going to be asked about IM-17-hydroxyprogesterone, which is quite popular among many providers. The Cochrane actually did include a nice table on that. And as you see, the studies that the RCTs that have looked at this intervention were from the 60s, 70s, and 80s, and none of them showed statistical significance. There was an update to the Cochrane that was published in 2018 as an update to the earlier one that we just showed. Now we're up to 7 trials with nearly 700 participants, and the results were again in favor of progestogens with a nearly 36% risk reduction. The same sub-analysis was conducted with oral studies, now 3, versus vaginal studies at 4. And again, the oral sub-analysis was actually in favor, but there was no statistical significance with the vaginal progesterone sub-analysis. This is kind of a nice summary for this most up-to-date Cochrane, which was published in 2018. So positive results for the oral route, no significant results for the vaginal route. Now, this is all what we had up until 2018. Relatively small studies required a Cochrane to include them all, with the most up-to-date published in 2018. Comes 2019 with a landmark study by the name of the PRISM trial that was published in the New England Journal of Medicine out of the UK. It was a randomized double-blind placebo-controlled trial conducted in 48 hospitals. It was funded by the UK National Institute for Health Research Health Technology Assessment Program. It included women aged 16 to 39 who were less than 12 weeks of gestation, who presented with bleeding with evidence of an intrauterine gestational sac. Those women were randomized to vaginal progesterone at 400 milligrams suppositories or a matching placebo twice daily, and treatment was continued up until 16 weeks of gestation, as you see here. The primary outcome was actually live birth at or greater than 34 weeks of gestation, although the authors did include neonatal outcome up to 28 days post-birth. This is one of the largest studies in history, with over 4,000 women randomized to about 2,000 in each arm. So it is indeed the largest trial on this topic. What were the results? It was actually a negative trial with no difference in the live birth rate, which was the primary outcome between the progesterone and the placebo group, with the secondary outcomes no difference in ongoing pregnancy rates at 12 weeks or miscarriage rates. So the conclusion: among women with bleeding in early pregnancy, progesterone therapy administered during the first trimester did not result in a significantly higher incidence of live birth than placebo. There was actually a number of sub-analyses, actually 10 subgroups. Only one group demonstrated statistical significance, which were women who presented with bleeding with history of 3 or more previous miscarriages, as you see in this table. Now, the issue with that is that this specific question was actually, research question was actually addressed by the PROMISE trial by the same group, which we're going to see shortly. But we have to note that this was the only subgroup analysis that was actually of positive results. Now, in 2021, just a few months ago, there was a trial published in Human Reproduction. Again, one of the largest studies on oral dydrogesterone this time. It was a randomized double-blind controlled trial out of Hong Kong. It was funded by the Health and Medical Research Fund, and by the government. A total of 400 women were included. Inclusion criteria: 18 to 40 years, gestational age 5 to 12, evidence of intrauterine gestational sac. As you see, it was a smaller trial compared to the earlier one, compared to the PRISM trial. In that study, the other difference was that the authors or the investigators used oral dydrogesterone rather than vaginal progesterone, and the dose was 40 milligrams orally, followed by 10 milligrams TID or placebo until 12 weeks of gestation. The primary outcome was miscarriage rate before 20 weeks of gestation. This is the study flow. You see about 400 women randomized, 200 in each arm. Results, a negative trial, once again with miscarriage rate before 20 weeks of gestation being similar in both groups. The authors also looked at the live birth rate, which was again similar between the two groups. Now, the issue with this study, according to the authors themselves, is that there was concern for a small sample size. Our sample size was larger than published trials using oral progestogens. Definitely, it was a larger study, but not adequate to demonstrate a smaller difference in the miscarriage rate between the progestogen and placebo groups. Other limitations that were cited or that were identified was an issue with the inclusion and the exclusion criteria. We always wonder about the importance of viability. Is it important? Is it not important? Should it play a factor in starting the medication or not? In that study, viability was not confirmed in up to 15% of patients, and this may have impacted the results. Selection bias, most of the patients had mild symptoms in this trial and had relatively better prognostic factors. Again, this could have played a role. Follow-up and withdrawal, there was a dropout rate of nearly 20%. In the PRISM trial, that was significantly lower. Discrepancy in the compliance, up to 46% of placebo participants were non-compliant with the treatment. The authors had a very few patients with chromosomal testing, which is an issue in most trials, actually. And finally, another concern was that the authors stated that the primary outcome was not available in 9 and 8 women in the progestogen group and the placebo group, respectively. We assumed that all of these women had a miscarriage. So in a relatively small study, those small numbers could actually impact the results. So this is basically all what has happened in the threatened abortion scene. As you see, a lot of action. The PRISM trial has certainly impacted the clinical practice when it comes to the use or the adoption of vaginal progesterone for the use in the setting of threatened abortion. When it comes to oral dydrogesterone with these recent studies, I think we're yet to see if such a study is going to really impact clinical practice. Ending our discussion with the second topic, which is recurrent pregnancy loss, a very challenging and frustrating topic to engage in and to approach. But we do see those patients, especially in the setting of busy practices. Although only up to 5% of pregnant women experience 2 consecutive losses and up to 1% experience 3 consecutive losses. But again, in the setting of tertiary care centers or busy clinical practices, these patients are encountered. These patients are very challenging. They tend to come feeling down, feeling helpless, and they turn to us to try to figure out why is this happening, and we go ahead and we counsel them about all those potential etiologies. We perform the $1 million workup, as you name it, but we're often left with 50% of cases where we cannot identify a cause. And I think you all agree with me that this is one of the most awkward moments where you just have to stare at the patient and say, you know what, I really don't know why you've lost 6 babies, why you've lost 10, 11, 3, 4. I mean, we've all had those really, really challenging cases. So what do we do to Sarah? Sarah has had 3 losses. She's lucky. She didn't have more than 3, but we've had cases of 7 or 8 or 10 or 11 who are less lucky than Sarah. Sarah is still very unlucky with 3 first trimester pregnancy losses. Her complete workup was unremarkable, and she comes to you and says, "Doctor, what are you going to give me? Nothing? My sister had a very similar history, and her doctor gave her aspirin. And my neighbor got aspirin and heparin. And my cousin got vaginal progesterone. And my coworker had oral dydrogesterone. You're not going to give me anything? It makes no sense." So what are we going to give her? Well, I think when it comes to anticoagulation in the setting of unexplained recurrent pregnancy loss, the NHS in a green top guideline back in 2011 has really elegantly stated that aspirin alone or in combination with heparin is being prescribed for women with unexplained recurrent miscarriage with the aim of improving pregnancy outcome. 2 recent randomized controlled trials reported that neither of these interventions improved the live birth rates among women with unexplained recurrent miscarriage. And both of those studies were published in 2010, one in the New England Journal of Medicine and the SPIN trial in Blood. So yes, some colleagues would adopt that, others wouldn't. So if we don't, and we follow evidence-based medicine, are we gonna leave the patient with nothing? Should we try progestogens? Should we consider vaginal? Should we consider oral? Well, let's go through an evidence-based journey of the most recent studies that has looked at this topic. 2013, a Cochrane looked at the overall use of progestogen for preventing miscarriage. They included, as you see, all kinds of patients, including the routine use of progesterone. And as you see, when they looked at the big picture, progestogens really didn't work. So when you included all kinds of patients, it really didn't work. But the group that we're interested in is that sub-analysis 3.1, which are women with a history of 3 or more prior miscarriage. And as you see here, there was actually a statistically significant reduction in miscarriage rate with the use of progestogens. So in women with recurrent pregnancy loss, according to that Cochrane, it did appear to be beneficial. So although there was no evidence to support the routine use of progestogen to prevent miscarriage, there was actually evidence of benefit in women with a history of recurrent miscarriage. So that was kind of a let's say conclusion or a summary of most of the studies, which were of relatively small size up until 2013. 2014, there was a randomized control trial published out of India in fertility sterility in 2014 by Kumar et al. It was a randomized double-blind placebo-controlled trial. So again, adequate study design like the studies that we mentioned with threatened abortion, examining the effect of dydrogesterone on pregnancy outcome in women with a history of recurrent pregnancy loss, 3 consecutive miscarriages. 3 groups were compared for that purpose. Women with a history of 3 or more losses were randomized to either dydrogesterone 20 milligrams per day or placebo. And as you see, it was a big trial with nearly 200 women in each arm, which is not easy to get 400 patients with recurrent pregnancy loss. It is a big center. Treatment was given from confirmation of pregnancy until 20 weeks of gestation. Women with no history of recurrent miscarriage served as controls and received no treatment. The trial was a positive trial with a significant reduction in miscarriage rate from 16.8 with placebo to 6.9% in the dydrogesterone arm. 2015, an even larger trial was published by the same group that published the PRISM trial. This time it's the long-awaited PROMISE trial, which was a multi-center trial conducted in the UK and Netherlands. It was definitely another landmark trial investigating whether treatment with vaginal progesterone would increase the rates of live birth and newborn survival among women with unexplained recurrent miscarriage. Women were randomly assigned to receive twice daily vaginal progesterone suppositories, 400 milligrams, or a matched placebo from the time soon after a positive urinary pregnancy test until 12 weeks of gestation. This is the study flow. Here we're up to 400 women in each arm, so about 800 in total, and these are the results. There was actually no difference in the miscarriage rates or in the live birth rate at 24 weeks and beyond between the progesterone group and the placebo group. In other words, it was a negative trial. In 2020, the same group, Ari Kumarasmani, published this expert review in the American Journal, in the Gray Journal. It was a systematic review and meta-analysis of progestogens in the treatment of threatened and recurrent miscarriage. It was actually a very nice review looking at all trials of adequate design, examining the role of progestogens in the setting of threatened miscarriage as well as recurrent miscarriage. And in the threatened miscarriage studies, the study that stood out was one by Pandian in 2009 that showed positive results with the oral route. And for the recurrent miscarriage, only the Kumar trial that we just published showed statistically significant reduction with the use of the oral route or the oral dydrogesterone in the setting of recurrent miscarriage. How does this translate to recent guidelines? Well, the American College, for the first time, actually, that was an unusual move, has actually published its practice bulletin in 2015 that has alluded to a potential role for progesterone. As you see here, women who have experienced at least 3 prior pregnancy losses may benefit from progesterone therapy in the first trimester. ISHRI actually have revised their the ISHRI, European Society of Human Reproduction and Embryology, has revised its guidelines when it comes to the management of recurrent pregnancy loss, following, of course, the PROMISE trial. Vaginal progesterone during early pregnancy has no beneficial effect in women with unexplained recurrent pregnancy loss. There is some evidence that oral dydrogesterone initiated when fetal heart action can be confirmed may be effective. So basically the guidelines are in alignment with the literature that we just discussed. And with that, I end my talk and I thank you very much for your attention.
Thank you, Dr. Fadi, for this very nice lecture. I know, as usual, you always experienced in progesterone and recurrent and threatened miscarriage.
Thank you, Dr. Naz.
Thank you. I think we have to answer the questions first from the audience. There is a question from Kariman Ghazal. She's from Lebanon, and she is asking if we have, is there a relation between the prenatal progesterone and PCOS in the newborn?
Not to my knowledge. I don't know. What do you think, Dr. Mazen? But to my knowledge,
I don't. Yes, I am with you. There is no reported cases because most of progesterone have non-androgenic effect. And that's why you're not going to see any features like hypertrophy of the clitoris. But you have to be careful if the patient, if the mother is having, or the baby have congenital adrenal hyperplasia. So you need to exclude this if you see the feature in the newborn, but it is not related to the therapeutic doses of progesterone given for the miscarriage case. There's another question, Fad, here. How long should the lady continue on progesterone supplementation for a threatened miscarriage?
So I don't think anyone has the answer to this question. It's one of the most controversial. And if you look at the literature, the studies did them differently. You have studies that continue up to 20 weeks, studies that continue up to 12 weeks, studies that continue up to 1 week. So it may be a little bit easier with recurrent miscarriage. I think with recurrent miscarriage, if you look, I've looked at protocols from different centers. Although the Kumar trial has continued up to 20 weeks, and you have some protocols that continue up to 20 weeks, when it comes to most centers, they continue up to the end of the first trimester, basically, you stop. This is when it comes to recurrent miscarriage. When it comes to threatened miscarriage, it's more gray. I think I've seen protocols, or I personally go for 1 week of no bleeding, and then you stop. I've seen some centers continue up to 12 weeks, so they're kind of treated like recurrent miscarriage. I think we have to engage the patient in that decision, just like we engaged them in the earlier talk with diabetes. So here we have to engage the patient. That's kind of the evidence. It's limited evidence here, limited evidence there. We can stop at 1 week. You can continue. If you feel there's some resistance, you can continue a little bit longer. But I think a period as little as 1 week post the last bleed could be effective.
Yes, I agree with you, Dr. Fadi. Between 5 to 7 days after the last day of bleeding, that's for threatened. But in case of woman who had a previous 1 or 2 miscarriage, where we can't say she is having recurrent miscarriage, and if she is threatening in the 3rd pregnancy, then we may consider her like recurrent miscarriage, and we continue minimum to 16 weeks. And I agree with you, some say between 16 weeks is enough, because that time the placental progesterone has risen up and past the decline of the corpus luteal progesterone. That's most people say 16 weeks is adequate, but if you go for 18, I don't think there is any harm of continuing till 18 weeks, till 20 weeks.
The larger, I mean, the Kumar trial went to 20 weeks. It's true.
Sorry, again?
I'm saying, Dr. Mazen, the Kumar trial went up to 20 weeks.
Yes, up to 20 weeks. Because this woman, although there is no evidence that women who have a threatened miscarriage, there is increasing risk of having a premature birth. So some women who have threatened miscarriage, maybe they need to be assessed regarding risk factors, whether placental location or cervical assessment by ultrasound, because if they are at risk of miscarriage, if they are at risk of a preterm birth, they may continue on a progesterone, whether you're giving them oral progesterone or vaginal or intramuscular progesterone. Thank you, Dr. Fadi. I know this topic is it causes us a lot of concern, because some women may say, with those with a threatened miscarriage, I like the question which you put first, not to do anything or do something or give aspirin or give low molecular weight of heparin. I always say threatened miscarriage like a toy, which is pregnancy is hanged by a thread. If you cut the thread, it will come out. If you pull the thread up, you keep the baby in utero. So how much you can pull on the thread to keep it in, or how much you leave it to become loose and will cut off and the pregnancy will come out. So sometimes whatever we do, we're not going to get successful. And that's we say, maybe we are not doing very excellent jobs, but we are treating psychology as well, because a lot of papers came in the early after from the people who did the PROMISE study, like the ex-president of the Royal College. She reported cases where there's nothing to be done, and maybe successful pregnancy may reach 70 to 75% in cases of recurrent miscarriage. I know that tender loving care will be effective, and psychological support, and maybe giving them just routine minerals and vitamin supplementation will do. I'm not saying we should not use progesterone, but you have to balance the benefits. And I think you reviewed most of the updated articles and reviews. I think when we give progesterone, you are losing nothing. And if become successful, you will be congratulated for that. Thank you, Fadi. And at the end, I think there is no more questions. At the end of this webinar, I would like to thank our colleagues and our distinguished speakers who shared with us this excellent webinar. And at the same time, I would like to thank Dr. Abir and Dr. Maher and all the committee's members for their hard effort to make this meeting or webinar successful. My sincere thanks to Abut also for supporting this activity. And we hope to see you face-to-face here in Jordan in the future. And I know, Fadi, you've been here before, but our colleagues from UK, we haven't seen them here. I would like to say, we hope when the pandemic is over, in the next year, we hope to have congresses here in Jordan, whether the Royal College Committee or the Jordanian Society of OBGYN will have their congress directly, and we would like to see them here in Jordan. Again, I would like to remind our colleagues in Jordan and outside in the Middle East region that the next webinar will be on the 16th of July, on Friday. It will be session 2 on medical disorders or medical diseases in pregnancy. Dr. Maher is going to organize this webinar. Is Maher here? Dr. Maher. Dr. Maher,
Sorry. Dr. Fadi, thank you for your excellent presentation. I think our next webinar will be in 2 weeks' time. It's medical disorders in pregnancy, if you like, part 2. Dr. Hassan Shahate in the UK and Amir Gharaibe in Jordan will be organizing this webinar. And that Middle East webinar, and that will be interesting. Dr. Fadi, I'm not sure if you are involved in maternal mortality.
Yeah.
Need a speaker from Egypt and Saudi Arabia so we can have a look at maternal mortality in our region. What are the what are we doing to reduce it, and what are the figures? So that's something that we all are looking forward to. Dr. Thank you very much, and we will see you in 2 weeks' time.
Thank you. Have a good night, everyone.
Thank you, everyone. Thank you, Fadi. Thank you, all our speakers. Thank you, Maher and Abir, and good night for everyone. Best of luck.
Good night.
Good night. شكرا إبراهيم.
عفوا دكتور، عفوا، شكرا.